Good morning. Good morning. Oops. Wait a minute. There you go. Try that again. Good morning. Sorry, y'all. The traffic getting here today from all directions was tricky for everyone. So, but most of us are here, and I think we may have another one or two straggle in. But thank you. My apologies for the late start. Welcome. We are about to have a great discussion, I think. I look forward to what we're going to be discussing today. This is going to be the first of 5 meetings for this study committee, and the goal is to understand the current landscape of both the country and our state, and how we as a state can move towards more choices for consumers. To be very clear, we're in no way stating opioids are not a valuable tool in the tool belt to help patients all across our state. But we are here to learn and determine if there are other tools that can aid patients according to the needs that they have. Before we get started, and as everyone catches their breath, I'd like to ask y'all to pause with me for just a minute and let's open with a prayer before introductions. Please bow with me. Dear Heavenly Father, we come to you today, rushed, pushed, but anxious to try to help in the work that you're laying before us. I ask that you give us all ears to listen, eyes to see, and hearts filled with compassion to tackle this challenge that is so very real, not only in our state, but across our entire nation. In your name we pray. Amen. So I'm Katie Dempsey, privileged to chair this conversation. And I want to just start down the row, and we're going to work on the numbers. We have a new screen here. So if I don't hit them quite right, we will try. If we can start to my right and give everybody else a moment to introduce themselves to one another and to the members and to the listening audience as well. I think we're at 26. Does that look like your number right there? Okay. And if you'll punch the little button right there, great.
Hold down the button.
You can let go.
My name is Adam Kay. I am a citizen representative. I myself am in long-term recovery from opioid addiction and have lost many friends and family, unfortunately, to this disease. So hopefully I can provide some perspective there. I'm also a real estate attorney by day. Thank you. Happy to be here.
Thank you. And I think our next number is 23. Is that right? Let's see if that works.
Yes.
Good.
Thank you, Madam Chair. And everyone, Mark Newton. I'm a representative from Columbia County in Augusta, Georgia. My daytime job is an emergency physician. So this is something we've seen, both the need for when pain control is needed. We see that a lot in the emergency department, but we also see the complications in our behavioral health area that are just drastic and devastating, as Chair Lady Dempsey said, to families across Georgia. Looking forward to hearing from everyone the challenges and where we can give some direction as a state.
Thank you.
Good morning. I'm Representative Lee Hawkins. I chair the Health Committee. I'm a retired dentist, and in that role for the first 10 years, I also did a hospital dentistry at Northeast Georgia Medical Center, did a lot of my own surgeries and pathologies and biopsies and that kind of thing. So I had a use for pain management over those years. Toward the end of my career, for the last probably 10 years, I did very little surgery and actually dropped my DEA part of my license, for the controlled substances. So I've seen both sides of this issue and eager to learn more. So, thank you.
Thank you so much, Jesse.
Good morning, Madam Chair. My name is Jesse Wethington. I'm the president of the Georgia Association of Health Plans. So I'm here to represent the perspective of the health insurance industry. But prior to that, I've had the privilege of serving on the House staff for a couple of members of this committee, Chairman Parrish and Chairman Cooper, who are not present yet this morning, as well as represent various interests in both pharmaceutical manufacturing as well as technology companies that deal with this program. So appreciate the opportunity to be here and serve on the committee. Thank you.
Thank you. And let's go back to Representative Gladney.
Good morning. Thank you, Madam Chairwoman. I was supposed to ride with Representative Mark Newton this morning, who is my colleague from the Augusta delegation. He left me in the carpool, so I had to drive. Just kidding. But I represent House District 130, which is the Augusta area. We are fortunately blessed with the resources of Charlie Norwood Hospital, uptown, downtown, and the what we call the Blue Goose affectionately, which is the Georgia Ward Nursing Home. And we see a lot of veteran community, but we also have a very large healthcare community in Augusta University, Piedmont, and all of the university health system. So we have a significant interest in understanding how this is affecting our community. And I lend all of my efforts and my support here to this committee.
Thank you. And let's see, down to my right, my far right, if you'll just punch that button, that'll be great. Thank you. Oops.
No, okay. I'm used to getting my outside voice. My name is Michael Pursley. I'm the Chief of Police, the Albany Police Department. And I am a champion for recovery, partnering with our local community service board, understanding that when I spent the first several years of my career putting as many people in jail as I could, you quickly figure out that we're not arresting our way out of the problem, and we don't have enough centers and treatment facilities that's truly needed. So I'm glad to have this opportunity to hear what some true champions are doing so that I can take this back to my peers and instead of working against the grain, let us work with the grain. So thank you, Madam Chairwoman.
Thank you. Representative Al.
Good morning, everyone. Thank you, Madam Chairwoman. My name is Representative Michelle Au. I represent House District 50, which is Johns Creek and a little bit of Alpharetta. And in my day job, I am a practicing physician. I'm an anesthesiologist in the Metro Atlanta area. Obviously, as an anesthesiologist, I spend a lot of time every single day thinking about opioid use, risk mitigation, and alternate pain therapies. So I'm really excited to see what people have to say here today, and also to continue to prioritize this issue because we recognize that perioperative care is a key point in which we feed into this opioid epidemic in this country.
Thank you. Miss Payton.
Hello, I'm Taylor Payton. I am the opioid abatement liaison for the opioid settlement within the Georgia Department of Behavioral Health and Developmental Disabilities. I'm also a person in long-term recovery and have worked in recovery, treatment, prevention, and research for the last 8 years. And I'm incredibly honored to be here and for this opportunity. Thank you so much.
Sorry. Thank you. And Dr. Wang.
Good morning. My name is Alan Wong, and I'm the CEO and Chief Physician Executive for Salud, the Art of Recovery, and the Reiser Institute in Suwannee in Gwinnett County. I'm a physician, internist, hospitalist by training. Previously professor at Emory for 15 years, was their division chief and former chief medical officer at Emory Johns Creek Hospital. And I have trained during the 90s for my medical education. And during that time is when the opioids came to rise, and where we as physicians were part of that initial, big push to have opioids out there. And as we know now, all the data and other things that occurred were not right. As an internist, we practice to look at obviously a lot of alternatives to not just opioids, but to medications and procedures in general. If you look at this country versus other countries around the world, prevention is not a huge push for us. And if you look at the other countries, the rate and their use of medications, procedures is going to be less than what we have here. So I'm really proud and honored to be part of this committee on how we can make a difference here and look at all these different alternatives, not just other pain medications, but other alternatives and a holistic approach to help with pain management.
Thank you so much. We do have one member of the committee that's joining us online too. And I think if Morgan, if you can, do we have to do? We're. Jeff, can you introduce yourself?
Hey, yes, ma'am. Thank you, Madam Chairman. Yes, ma'am. My name is Jeff Breedlove. I am a person in long-term recovery from active addiction. I was in active addiction for 30 years, and I've known the hope and joy of recovery for just under 8 years. I live in Grant Park, Georgia. I work for the Georgia Council for Recovery. And I just want to say, I apologize for not being there in person, but I do have a good excuse. I'm at the 17th Annual Georgia School of Addiction Studies in Savannah. And I just had the great privilege of being on stage with Commissioner Kevin Tanner of BBHCD doing a little conversation about behavioral health. But please accept my apologies for not being there in person.
Thank you so much, Jeff. Before we get started, we have a sign-up sheet. If you would like to make public comment later in the day, it is on the table right here. And if you'll just put your name and who you're here on behalf of, that would help us, and we will get to that later. We'll also be taking a break in just a little while, and you can sign up then as well. Okay. Okay. So here we go. Been working on this for a little while. Many of you in this room have also been working on it. So let's get started with our first presenter, representing Voices for Non-Opioid Choices, Chris Fox, the Executive Director. And Mr. Fox, if you would, when you can sit here or stand, whichever's more comfortable for you. If you would introduce yourself and tell us all a little bit more about you.
Thank you. Good morning, Chair. Good morning to the study committee here. My name is Chris Fox. I am the Executive Director of Voices for Non-Opioid Choices. I'll tell you a little bit more about our coalition. We are based out of Washington, D.C., and we were formed about 5 years ago amid a growing opioid epidemic. We'll tell you a little bit about what the need for our coalition was, what problem we aim to solve, and a little bit more context laying about exactly what the scope of the problem is nationwide when it comes to the opioid addiction epidemic. I've been asked to, this is a little bit of the scope of what I propose to cover here today. So I'll tell you a little bit about more about the coalition, who we represent, a little bit more about the opioid epidemic generally that has gotten worse, not better, despite hundreds of billions of dollars in federal and state investments in very worthwhile causes, I would argue. Things like support for first responders, increased access to recovery services, naloxone availability in communities across the country. If I may be so bold, I would say that all of these attempts are attempts to help individuals who are in an acute crisis situation. They're an attempt to pull a drowning victim out of the river. And as I'll show later, we're not really particularly very good at it. And so what we did at Voices was we tried to do things a little bit different. And we tried to look at a pathway to addiction that can start with prescription opioid pills, try to figure out how we can do better by those patients by helping them access non-addictive pain management approaches, and what that meant for them and what the opportunity is and what barriers existed, frankly, in making those options available to those patients. I'll give a brief overview. I know there's a lot of healthcare expertise on this panel here this morning, but I'll give a brief overview. A lot of folks say that they don't really know what non-opioid pain management looks like. I can assure you almost everybody here has heard of it, but we'll talk a little bit about it as well as its benefits. There are some fears and I think myths associated with non-opioids, particularly that they might not be as effective as prescription prescription opioids. And so there's a lot of evidence to the contrary when it comes to that. And so we'll go through a little bit of that. And then I'll talk through what those barriers were that impacted access to non-opioids. I will say that in general, all you have to do is follow the money, unfortunately. And as you might know, a lot of these prescription opioids are available in generic form right now, which makes them very attractive options for individuals and potentially those who might make them available to patients. So finally, I'll wrap, if it's okay, with just a discussion of what's next, where we are now despite some policy change, and what the opportunity might be in this state and around the country to make sure that every patient in every care setting has access to a non-opioid. So briefly about Voices for Non-Opioid Choices. As I mentioned, we were formed in 2019. The National Institute on Drug Abuse estimated that at the time, we were losing 115 Americans to an opioid-related drug overdose. Well, if you fast forward just 5 years, today, according to the latest estimates from the Centers for Disease Control and Prevention, we lose 215 Americans every day to an opioid-related drug overdose. Clearly, this is a problem that can't be solved simply by throwing money at it. So at Voices, we firmly believe in the power of the collective. We believe that 3 voices are more powerful than 1, 5 more powerful than 3, and 200 more powerful than 100. So we've assembled an umbrella that has come together under a shared vision, which is that we can and we have a responsibility to prevent opioid addiction in the United States simply by increasing access to and use of non-opioid pain management approaches. Now, I'd like to echo a statement that Madam Chair made just earlier, which is that Voices in no way, shape, or form is anti-opioid. We believe that there is a time and a place for those patients to access those medically necessary approaches. However, we can't take a one-size-fits-all approach to pain management. As many will tell you, pain is personal, and despite some years of treating pain via prescription opioids, we now know what risk profiles those come with, and we now know that we have the ability to treat pain without prescription opioids. And so for us, we are not anti-opioid. We are just in favor of giving patients, caregivers, and families choices in what pain management looks like, and hoping to facilitate some conversations between healthcare professionals and those individuals about what their pain plan might look like. So I'll give a quick overview of the opioid epidemic in the United States. Before I do so, just quickly, the state of opioid use disorder in America, there are just more than 6 million Americans with an active opioid use disorder right now. This is, or I should say, that was 2022 numbers. This is from SAMHSA. If you look at substance use disorder, generally, it's more like 23 million Americans across the country. If you want to take just a snapshot of that, and I will just for sort of a pilot case study, if you will, we took a look at, in the Medicare population, what the incidence of opioid use disorder was. And there was an Office of the Inspector General study that was conducted that found that in 2022, there were 1.1 million Medicare beneficiaries with a diagnosed opioid use disorder. I want to underline this word diagnose because it's important. That is a medical diagnosis. That is not just a grandma or grandpa takes their medicine at night and gets a little silly before bedtime. This is a medical diagnosis that has been given to an individual. And so of those 1.1 million Medicare beneficiaries who had an active diagnosis in 2022, 145,000 of them were newly diagnosed in 2022. And so we did a look at what that cost Medicare in 2022 alone. I shouldn't say we, I don't have, the only fancy letters I have after my name are FOX. So we had people with much fancier letters after their name do a look at what that cost Medicare. And they found that the total cost of OUD to Medicare in 2022 was $33 billion. This is a one-year figure. If you want to look at just those newly diagnosed with an opioid use disorder, those 145,000 Medicare beneficiaries, the cost to Medicare was $4.3 billion. Again, in general, what we're talking about is approximately $30,000 per person add-on with an OUD diagnosis. And so if you want to take that, if you want to assume that for the general population, that same cost is applicable, you're looking at potentially a cost of $165 billion of OUD to the United States healthcare system. So in addition to the human element, and I know we have some in recovery here, I just want to make sure that we just not give short shrift to this. There's also a very real economic component to this epidemic. You may have seen that a couple months ago, the Centers for Disease Control and Prevention put out updated drug overdose numbers. Some coverage of these numbers were a little bit flowery. There were roughly 3% reduction in total number of drug overdose deaths in the country from 2022 to 2023. However, I would caution that our work is not done. In fact, it's far from done. When we're talking about a roughly 3% decrease in the number of opioid-related drug overdose deaths or drug overdose deaths overall, they're largely attributable to crackdowns on fentanyl. There are still patients that continue to receive opioids, sometimes in large amounts, and the issue of the drug overdose epidemic and the opioid addiction epidemic persists, unfortunately. And so our work is far from done. This is what the drug overdose deaths in the United States picture looked like from 2010 to 2023. So the total line there will show you the total number of drug overdose deaths. So again, we went from about 110,000 US deaths lost in 2022 to a drug overdose to about 107 in 2022. Roughly 3/4 of these are opioid-related overdose deaths. It's hard to just say that they are opioid overdose deaths because in large part, there are other substances found in these individual systems, whether that be marijuana or THC, I should say, alcohol, methamphetamines, or others. So I will call them opioid-related drug overdose deaths. But generally speaking, if you look at the blue chart there, you have seen a 4-fold increase from 2010 to 2023 in the number of opioid-related drug overdose deaths. Now, I talked about the slice of the pie that Voices focuses on, and the CDC is very clear that many of these deaths are attributable to fentanyl and illicit forms of heroin, and that is entirely accurate. However, what I want to talk about today is a path to addiction that can start by being exposed to a prescription opioid, either yourself via prescription from a procedure that you may have had or an accident or an injury, or via community diversion in the instances when there may be excess pills that are lying around in medicine cabinets and what can happen there. So again, while a lot of these deaths are attributable indeed to illicit forms of opioids, SAMHSA data shows us that 75 to 80% of those illicit opioid users initiate via prescription pills. And so it's not frequent that individuals start abusing these illicit forms of heroin via needle in the arm, but oftentimes there's a gateway, there's a pathway towards addiction that can start. And I want to emphasize this point. It can start with a single pill. And I don't want to just throw numbers at you. And so I'm going to intersperse, if that's okay. They're not in the slides here, but I'm going to interject some personal anecdotes from some of our coalition leadership and others. And so at this point, I want to note that someone on our board is an advocate. She lives in the Richmond, Virginia area. She paid the ultimate sacrifice in that she lost a son who was an incredible athlete and an incredible person who got addicted to prescription opioids after shoulder surgery. He was a tennis player in high school. He tore his labrum in his shoulder and he had surgery. And as with most, they prescribed him opioids to manage his post-surgical pain. He would tell his mother that the first time he took an opioid pill was the first time that he felt normal. It took him one pill to go down that path. He would later promise his mother that the one thing that he was going to do is that he was not going to die high. That was a promise he didn't keep. Tragically, he had a sister, and his sister was also an athlete, had the same injury. The mother fought tooth and nail because she had the wherewithal to, and she had the experience of knowing what had happened to her son. And she fought tooth and nail to make sure that her daughter would not be exposed, not because she didn't trust her daughter or not because she didn't think her daughter could handle them, because it was a risk that she didn't want to take. So that's just one. I'm going to tell you other harrowing stories. I know we have some time to talk later. I'm happy to share some of those other anecdotes, but this is sort of what can happen. It's not what does happen, but we'll talk about sort of this pathway that starts potentially with one pill. So this might be my favorite slide of the presentation. I'm sorry, it might be difficult to read on the printouts, but this is a look at who's paying for and dispensing prescription opioids in the country. I apologize, it's a little dated from 2011 to 2019, but I want to highlight a couple things if I could. I don't know if I have a laser on this or not, but if you look at the far left there, when you have all the colors, in 2011, you had roughly 250 million prescriptions for opioids dispensed in the United States. Of those, you can see the different payer types there. Who was paying for these prescription opioids? And so you can see that we had some cash patients, we had some Medicaid patients, Medicare, and then commercial patients. If you fast forward over to the far right there, you can see 2019. What you've seen is you've seen a decrease by about 40% in the total number of opioid prescriptions dispensed in this country. So we went from about 250 million prescriptions dispensed to about 150 million in 2019. Well, the number I do have is if you fast forwarded that to 2023, we'd be down about 50%. There are about 130 plus million prescriptions for opioids dispensed every year in this country as of right now. But I want you to look at the share of who's paying for those opioid prescriptions from 2011 to 2019. Because as you can see in the commercial patients, that commercial slice of the pie is getting smaller. The cash slice of the pie is getting smaller. Medicaid is getting a little bit smaller as well, but you can still see that there are some challenges there. But if you look at the orange slice of the pie here, what you see is that it is pretty much flat. In fact, if I wanted to be really critical, Medicare's share actually went up. We went from 53 million prescriptions in Medicare in 2011 to 54 million prescriptions for opioids in 2019. So while all other payers were decreasing opioid dispensing from 2011 to 2019, we saw Medicare actually increase the number of prescriptions. And as a result, Medicare's share of overall opioid prescribing in this country went up. It went from, again, 53 million out of 250 million, so about 20% of all of the country's opioid prescriptions dispensed, to about 35% of all of the country's opioids dispensed in 2019. That's a 75% increase in Medicare's share of opioid prescriptions from 2011 to 2019. Now, we know why some of these decreases have happened. Obviously, there are states like Georgia that have imposed some restrictions on the quantity or the days of number of opioid prescriptions that can be dispensed. I will say that, we are sympathetic to healthcare providers in this regard, that in large part, we're asking our healthcare providers to do more with less. It's akin to asking a carpenter to build that house, but I'm going to take away your hammer. And so for us, non-opioids present that real opportunity to say, okay, you may not be able to prescribe the same number of prescription opioids as you once could, but we're going to supplement that. We're going to give you other options and other tools, and we're going to make them available so that you can still build that house, you can still treat that patient just as effectively, but with a bit less of a risk profile potentially. Again, as I mentioned earlier, there are some patients who still continue to receive large quantities of opioids. I want to be clear, Dr. Wong, I think you said this earlier, the status quo in this country still remains today that we treat pain with opioids. Period, full stop. That's despite all the Netflix documentaries that you've seen, all the information that you've seen, all the lawsuits that you've seen. We still continue to treat pain with opioids by and large. Now, the quantities may be different than they were in the past, but as you can see here, up to 90% of acute pain patients receive a prescription for opioids to manage their pain. Now, I want to differentiate here too, because I'm talking about acute pain patients. These are episodic pain patients, so either an accident, a trauma, a sports injury, or a surgery. These are patients who should be time limited in their pain. These are not chronic pain patients who live in daily debilitating pain who may require the assistance of a prescription opioid simply to get out of bed in the morning. Again, it's a different type of patient, so it's a different patient population that we're attempting to solve for. And we know why these patients continue to receive opioids by and large. We know that doctors, again, we're sympathetic. Doctors, surgeons, healthcare professionals in general are trained to treat pain with opioids. It's what they know. It's what they're comfortable with. They've done their residencies in pain management with prescription opioids. And so we're comfortable. Now, this is starting to change a little bit for the good, but by and large, physician training, as I'm sure everybody on the panel knows, had started with prescription opioids. For others, we know that there's a little bit of, again, I'm sympathetic. No healthcare professional wants to get a call at 2:00 in the morning from a patient that they may have operated on, writhing in pain, saying, "What did you do to me, doc?" Or take this away. And so we understand that in some instances they're used as in rescue cases. And again, I come from the generation, I'm a little bit older, and so I come from the generation where I was told to stay ahead of the pain. Do you remember this? Anybody here? Does this resonate? Like you would take the pain pills before you were in pain. Well, we know better now. That's not actually treating pain. That's just distracting the brain from actually what you're feeling. And so we know better now. And so there's a little bit of a clinical practice lag. There's also lack of awareness about what non-opioid pain relief looks like. And so I know it might not exist here. We'll talk a little bit about it in a second and what the benefits are of it. But there's a general lack of awareness on both the clinical side as well as on the patient side. Again, I told you I would sprinkle in some anecdotes here. So I'm a father. I have 2 young sons. My one son underwent surgery last year for his tonsils and adenoids. And I remember we were pre-op. I had the gown on. He had the gown on. And there was a nurse practitioner that was there saying, "Well, what are you going to do for his pain?" And I told the nurse practitioner at the time, well, we have the ice pops, we got good old fashioned acetaminophen and ibuprofen that we're going to rotate him on and off. And the look that she gave me, that I had not considered making available to him a prescription opioid in case he was writhing in pain, made me feel like a bad father, to be very honest with you. Well, that nurse practitioner didn't know the fight that she was picking with whom and on what day, because she had clearly picked the wrong fight with the wrong father on that day. And my takeaway from that wasn't pride or I wasn't happy that I had successfully defended my son, but I was sad that I knew that other parents didn't have the wherewithal to push back like I had. And so this lack of awareness, I think, stems from, we need to make sure that parents, caregivers, individuals know that they can ask questions, that with all due deference to those with the fancy letters up here on the stage, that we don't have to simply take an opioid prescription because it's given to us, and that we do have the right to advocate for ourselves or our loved ones or our children. In that case, we did. And so, again, I promised I'd circle in some personal anecdotes. I don't want to just keep throwing numbers at you because I fear that they will be forgotten, but that's just one more. This is the problem, really, that Voices for Non-Opioid Choices was formed to solve for, which was long-term opioid use after surgery. So for some, the path to addiction, as I mentioned, can start when they are given a prescription for opioids. There was a recent study that came out 2 weeks ago that said that 10% of patients who were given a prescription for opioids after surgery became opioid dependent or developed an opioid use disorder. Now, I want to underscore those words because they're important. Most of the dialogue that we use when we talk about opioid use after surgery talks about misuse. Well, again, I know we have some medical expertise up here on the panel, but misuse means that you are taking that prescription pill anyway other than what's on that label. So if I take that pill every 3 hours as opposed to every 4 hours, I'm misusing that prescription opioid. So that's a very low threshold. Opioid dependence means that I'm making plans to get my fix that day, that I need to know that at 6 o'clock, I'm going to have those pills in my hands or in my mouth. And opioid use disorder obviously is another threshold, a further threshold that requires a medical diagnosis and makes available other treatment options for you. So again, our problem that we're trying to solve for is, how can we prevent those 10% of Americans who may develop an opioid use disorder or an opioid dependence following exposure to prescription opioids after surgery? How can we prevent that? And again, our answer and our mission is that we do that not by denying access to medically necessary medications, but simply by giving patients, families, and caregivers a choice. Here's a choice. Here's something else that you might be interested in. And here's a non-addictive option. So this is the problem that we try to solve for. Again, I promise some anecdotal evidence here. I know I'm happy to provide resources to these stories that they've been published in newspapers around the country, but I think it's appropriate at this point to mention that there's another advocate that we work very closely with. She's on the West Coast. She also suffered the ultimate tragedy in losing a son. Her son underwent wisdom tooth extraction. I know we have a dentist here on the panel, and so Representative Hawkins, I fear telling you the number of opioid pills that this gentleman was able to get after third molar extraction. But that number was 1,500 prescription opioid pills after third molar extraction. And so it's not really surprising to learn that he fought this pattern for about 18 years, and that ultimately that pattern led him to heroin, and he passed on the streets of San Francisco. Again, I could tell you these stories all day long. I hear them daily, weekly. It doesn't make them any less heartbreaking, unfortunately, but this is just sort of the reason that we're here and the reason for the work that we do. I want to talk a little bit about non-opioid pain management. We hear a lot, I don't know what non-opioids are. Well, yes, you do. Everybody here does. Everybody here has heard of ibuprofen, acetaminophen. I would venture to say, although you don't have to volunteer it, but I would venture to say almost everybody here has had oral surgery of some type at some time in their life. And if you have, you know that they give you that needle in the gums, right? And that needle in the gums feels like it's like 12 inches long, right? Once they stick it in there. And they tell you, they say, don't drink anything hot or cold for the next couple hours. Because if you do, you can do some damage. I'm sorry, I'm looking at the dentist while I say this. And you know that if you do, you can do some damage. And you also know if you take a sip of water, you're going to drool it all over yourself anyway because you haven't felt anything. Well, what they've given you is a nerve block. And those nerve blocks are non-opioids. And they come in formulations now that can last for up to 96 hours post-surgically. And oftentimes that can get patients over the hump where they would have traditionally taken a prescription opioid to manage their pain. More commonly, when we talk about what non-opioids are, the most common form are NSAIDs, non-steroidal anti-inflammatory drugs, and acetaminophen. So there are a couple of branded products here. There are other classes of drugs that have been used both on and off label that have some evidence of pain reductions, including anticonvulsants and antidepressants. But this is what non-opioid pain relief looks like. Most commonly, we like to refer to it as multimodal pain approaches, which is a combination. I'm looking at the anesthesiologist now, and so she knows very well what multimodal looks like. But it's a combination of these to lower the risk profiles and maximize the utilization of non-addictive approaches and minimize the utilization of addictive approaches to pain management. But this is what non-opioids look like. Now, there's a very real question for some about the effectiveness of non-opioid based pain relief. Well, I could rattle on and give you citation after citation about research about the effectiveness of non-opioids and the benefits of non-opioids. However, you don't have to take my word for it. And in fact, please don't. Just go around the corner. Centers for Disease Control and Prevention has been very clear about the effectiveness of non-opioid based pain relief. In fact, they have said in various iterations of their opioid prescribing guidelines, and these are quotes in here, so non-opioids should be used as a first-line therapy for acute pain, period, full stop. And non-opioids are just as effective at treating acute pain as opioids, period, full stop. So again, I just want to reiterate the caveat here that there are for sure patients that require prescription opioids. And this is in no way meaning to denigrate those patients or to decrease their ability to obtain those, to manage them in a medically responsible way. However, when it comes to the efficacy of non-opioids, the evidence is clear. They work and the benefits are substantial. So the number one benefit of non-opioid based pain relief is it minimizes what I would say is unnecessary exposure to narcotic based pain relief. If we can treat pain, acute pain specifically, just as well with a non-opioid as an opioid, it may make sense to some that non-opioids make a lot of sense and that they might not want to take that risk, that 10% chance that they or a loved one may develop an opioid dependency or an opioid use disorder. Additionally, opioids come with them a substantial risk profile, anything from gastrointestinal complications to that opioid fog, to falls, to ER visits, and others. And so the second benefit I would say to non-opioid based pain relief is reduced episodes of what we'd call ORAs, or opioid-related adverse events. I speak to a lot of clinicians on a daily basis, in addition to the one I'm privileged to speak with here this morning, and they would tell me that it is easy to treat patients' pain with opioids, to put them in a hospital bed and pump them full of opioids and get those pain scores of 0 all day long. However, what they would tell me, what they value most after surgery is not pain-free, but return of function. And so that surgeon will tell me all day long that I do not care if they are in discomfort, or maybe that do not care is too strong, but they care less that they are in discomfort as long as they are managing. But they care that a patient can walk home after undergoing a knee surgery, or they care that that patient can be returned home after shoulder surgery. These are major surgeries, and they care about the return of function. And non-opioids offer the opportunity to return those patients home out of the facility more quickly. And because of that, you have the opportunity to save healthcare resource dollars by shortening the lengths of stay for some of these procedures. Again, the number one benefit of non-opioid is the potential to save lives. If you can minimize exposure, you can minimize the odds of individuals developing an opioid use disorder. You can minimize the odds of going down that path that can lead you towards other illicit forms of opioids. And you can minimize the odds that we have to scrape those individuals off sidewalks and streets from across the country because, again, frankly, we're just not very good at it. I want to talk about some policies that have impacted access to non-opioids. I spoke earlier about some of the clinical practice considerations that have led to the situation that we're in. I also want to talk about what the impact of reimbursement policy has been on access to non-addictive forms of pain management. And frankly, some of the response, not just from the government, but from us. It may not be surprising to most, but prescription opioids are available in generic form in almost every case, and they are cheap. And that's why they enjoy almost universal insurance coverage. However, on the other hand, non-opioid based pain management options, while not expensive by healthcare dollars, we're talking about some cases $50 or $100, $200 in the case of some of the nerve blocks, while not expensive, they are more expensive. And because of the way that we reimburse for some of these procedures, it puts stresses on the profitability of these procedures at facilities. And so CMS took a look at the impact of its reimbursement policy. This look and this research into this came as a result of a federal request for them to do so. And they saw that utilization of non-opioids was lagging in certain surgical settings, particularly in ambulatory surgical care settings. And so in 2019, they adopted a policy change that said that beginning in 2019, if you are eligible to have your procedure performed in an ambulatory surgical center setting, that we will make available separate payment to the facility for the use of those non-addictive options. So again, I know we have a lot of healthcare expertise. I'm happy to get into the nitty-gritty of how this actually works in practice and questions if it's interesting. But what that did was it took the economic considerations out of play for the facility. It said that no longer do you have to take a haircut, for those that might have more hair than I do, but no longer do you have to take a haircut to give non-addictive forms of pain management. We will make you whole via separate payment. If I were giving grades, and maybe I'm a hard grader, but if I was giving grades, I would give this grade an I or an incomplete, because they did not make a similar policy change in the hospital setting, which is where the majority of procedures are performed every year. So we at Voices, my team and I, worked hard over several years trying to convince CMS that at the hospital setting, we also need separate payment. They should not have to make that economic consideration about whether they want to make available opioid or non-opioid based pain relief. Unfortunately, they didn't agree with us. Despite years and years, we even went to them and said, for sure, we can all agree that there are certain segments of the population that we should not re-expose to opioids. People in long-term recovery, for example. For sure, we can agree that those people should not be re-exposed. They didn't want to go there, didn't want to go there. So the policy was limited to the ASC, despite the fact that CMS, by its own words, did an impact analysis of what that policy change meant in terms of use of non-opioids in the ASC setting. And in 1 year, the first year that it was implemented, use of non-opioids more than doubled. So we have the best possible pilot study we could possibly have, in that we had a policy change that was made for the ASC setting. And in 1 year, use of non-opioids doubled. In fact, it went up 120%. So we know what happens when you change policy and you make separate payment available for the use of non-opioids. And so because CMS was reluctant to work with us in terms of making it available to the hospital settings, my team and I at Voices went to U.S. Congress, and we worked with Congress on a piece of legislation called the Non-Opioids Prevent Addiction in the Nation Act, short for the No Pain Act. This piece of legislation was bipartisan, bicameral, was supported by over 175 members of the U.S. Congress. Well, I'm sure you know as well as I do, getting 175 members of Congress to agree on a major policy change, let alone what's for lunch tomorrow, is difficult. And so this was a significant accomplishment, and I think spoke to the breadth and depth of the opioid epidemic that we faced. This legislation did one thing, was it took that policy change that was made in the ASC and it extended it to the hospital setting. And it will go into effect on January 1st, 2025. So starting in January, if you are an outpatient surgical patient and you are treated in a hospital or an ASC setting, that setting can be made whole for the use of non-opioid based pain management for you. It's a landmark success. We celebrated it for many with our advocates. That said, there are still gaps left behind. Who's not covered by this policy? We'll get to that in a second. What does this policy not do, and for whom and where? And we'll talk a little bit about that. So the No Pain Act was limited to Medicare. So that's thing one. So if you are a commercial patient and you are having an outpatient procedure, the No Pain Act would not necessarily mean that your facility would make available non-opioid pain management approaches to you. However, the general rule has been, and I know we have a representative from the plans here, so they can tell us as well, but as Medicare goes, has been the traditional sort of saying, as Medicare goes, others follow. And so the thought is that as Medicare goes, the commercial plans will follow. Medicaid potentially could follow. We'll talk a little bit more about that, as well as some of those healthcare systems that deal with our veterans, that treat our veterans. The other community that would not be impacted would be those on TRICARE. So TRICARE is an interesting case study in that they have told us that they intend to follow Medicare policy, and they traditionally do. However, the timeliness of following that policy is vague. There's no mandate on them, thou must follow this policy by X date or Y months afterwards. Instead, they do it when they get to it. And so, in the case of the policy change that was made in 2019 for the ASC, it took TRICARE 4 years to follow suit. 4 years. That's 320,000 Americans who will have died if rates continue the same from an opioid-related overdose until TRICARE decides that they're ready to follow suit in Medicare. Similarly, the VA. So the VA is another interesting prospect in that they have a formulary that decides what products are made available to their beneficiaries. However, the process for getting products onto that formulary is complicated, and right now carries an I would say, a generous amount of products that are used for cataract surgery and not others. And so we are working actively now with the VA to make sure that they are making available all clinically appropriate, FDA approved, non-opioid options on that VA formulary. So those who receive their benefits from the VA can make sure that they too can access a non-addictive approach and option. Medicaid is another interesting example. So traditionally, yes, it would follow Medicare's lead. However, they don't have to. And so obviously there's a lot of leeway, as you know well, in terms of what state Medicaid directors do and don't do based on some budgetary considerations. I will say the one benefit that we got from the No Pain Act, and the one piece that really helped push it over the top, was we got a piece of paper from the Congressional Budget Office, the federal bean counters, if you will. And the Congressional Budget Office told us that the No Pain Act was budget neutral, and that it would not add a single penny or dollar to the federal deficit by virtue of its being implemented. That largely comes because savings would have to be found elsewhere in the outpatient program, but also, we hope and we expect to see savings from facility costs. And we talked about those reduced lengths of stay and others. But generally, our hope is that Medicaid would see the value, particularly if you harken back to that $30,000 figure I cited previously about the cost of an individual when they develop an OUD, that Medicaid state directors would also see the value of reducing their risks of having individuals develop an opioid use disorder by virtue of being exposed to a narcotic for pain relief post-surgically. So we're working actively with payers right now to accelerate the adoption and the awareness of this policy change. But again, it's not going to happen overnight. The No Pain Act was passed at the end of 2022. It was signed on December 22nd, 2022 by President Biden. We eagerly are awaiting its rollout on January 1st. There's active rulemaking that's going on right now at the Centers for Medicare and Medicaid Services that we're trying to get right to make sure that it's having its optimal impact. But that's still work that remains. Generally, when I talk about needed next steps, and if it's okay, I'm going to start sort of in reverse order on this slide about what we think is needed here. I talked about patient and provider awareness. It's badly needed. And we would look forward to partnering with states like Georgia or others to let providers know, let patients know, this policy change is coming. This is going to be the rule of the road starting on January 1st. Let's work together to make sure that everybody knows about it. Every hospital system in the state, in the country, knows that you don't have to take a haircut if you give a patient a non-opioid approach. Let's sing it from the rooftops. Let's make sure that people know that if you are having a surgery and you don't want that opioid that may otherwise be prescribed, you don't have to have it. There are options, and the facilities can get made whole by giving it to you. So that's thing one. The other thing that we are working diligently on, and we know we have some challenges here, is we believe very, very much in the need to reimburse providers for having discussions with patients prior to surgery and develop personalized pain plans. As I mentioned, pain is personal to individuals. Individuals might have certain wishes and desires that others don't, but we don't have these conversations right now. Why don't we have these conversations? Because healthcare professionals aren't reimbursed to have these conversations. By and large, they would say that they're too busy to. Well, for sure, there are healthcare professionals who would be happy to have some of these conversations, and we're actively looking at how we can enact some policy change to make sure that these conversations are happening, so that we are at least giving patients a conversation to say, this is out there. Do you want this or do you want this? And, Dr. Wong, to your point, there are other non-medical interventions that have been demonstrated to help provide acute pain relief, things like acupuncture, things like psychological support services, chiropractic services. These are what we call sort of other therapeutic services that also offer the opportunity to provide non-opioid based pain relief for patients. So let's have these conversations. Let's facilitate these conversations between the providers and their patients, and let's make sure that we can have real choice and real sort of informed choice in terms of what pain management looks like after surgery. Similarly, we know we need to take the policy change that was included in the No Pain Act, and we need to make sure that it is sort of pulled through to other payer institutions, be it commercial, TRICARE, VA, full stop. We need to make sure that every patient in this country has an access to a non-opioid. And finally, and perhaps most importantly, we talked about access to some of these medications. Most of these medications are reimbursed out of a different part of the Medicare system, which is the prescription drug benefit, so Medicare Part D. And we need to make sure that Medicare Part D patients have access to not just the existing suite of available non-opioid options, but there are also an array of novel, innovative approaches that may be coming to market in the next couple of years. And patients deserve access to those. What I would say is that the federal government has invested billions of dollars trying to spur innovation in the non-opioid marketplace. Well, guess what? This is something that's gotten right, and that we're starting to see the fruits of some of this labor, and that the light is viewable at the end of the tunnel. We are starting to see that some of these products are having favorable results from clinical trials, and that patients should be able to access them. So put simply, patients, whether they get their pain management at the hospital or through Part D at the pharmacy counter, need to have access to not just available options that are out now, but also those novel approaches that may be out in the next year, 10 years, whatever it may be. Put simply, I'm agnostic when it comes to what pain treatment approach looks like. I just think if it's out there, it's been FDA approved, it's been deemed safe and effective, patients should have access to it, and they and their providers should talk about it and find out what makes sense for them. And I will not stop. At Voices, me and my team will not stop till every patient in every setting, in every community, in every state has access to a non-addictive approach. Thank you for having me.
Thank you so much. That was so very informative, and I value your personal stories that you shared with us too. Very, very good and great for us to have all of this as we eventually down the road in a couple of months put together a report on this committee. So thank you so much. I think we have our first question from Dr. Al, Representative Al.
Hi, good morning. Thank you for your presentation. One quick question to follow up. You had mentioned that there were some issues with formulary at the VA not covering or not providing or offering certain non-opioid based pain treatments. Can you talk about which medications those are that they don't include on formulary?
So I won't speak to any specific medications, just because, again, we are sort of the rising tide that lifts all boats. I will say that I'm happy to follow up with you and provide you the list of what those drugs on formulary are. However, there are a couple cataract drugs that they provide, mostly injected, physician-administered products that are used in cataract surgery in place of fentanyl, that are covered on the formulary right now, and that there are other nerve blocks that are not included right now on the formulary.
Okay. Are they certain classes of medications or?
No, they're specific drugs.
There's medications for non-opioid based pain control that are newer. So sometimes some formularies will be hesitant because they're not generic yet, so they cost more. Is that the issue? I'm just trying to.
Sure. No, that's not the issue. These are for sure they're branded drugs. They are not new. They are not unknown. In fact, many of these products are, according to the proposed rule that's come out for the in compliance with the No Pain Act next year, they are covered in terms of eligibility for separate payment according to the No Pain Act, yet they are not on the VA formulary.
And then just as a follow-up to that regarding pharmaceuticals, you had mentioned that there's some novel approaches being developed, and you don't have to mention any specific companies or drug names, but can you talk about the class of medication that they're working on and developing, just so we can...
Generally speaking, there are novel approaches that are not acting on the body's opioid receptors. And so they are utilizing other channels, specifically the body's sodium channels, and how they are able to treat pain. And there are some that are further in clinical development than others. But generally speaking, it is a new class of drugs. They are in various stages of development. Again, we're not going to speak to any specific drug name or manufacturer, but I'm happy to follow up and send you some news articles. It's been, we get clips daily. If you open up a news, I'm happy to send you some of the clips. There are a lot of manufacturers that are out there in this space.
So they're like local anesthetics, is that?
They're orals as well as local anesthetics.
Okay. And the reason I asked that is because there is what was marketed as a long-acting local anesthetic, a long-acting bupivacaine, that's the generic. that some places won't cover because it is much more expensive.
Yeah, for
And
sure.
there's some, questions about its efficacy, if it lasts as long as it says it will, but I just wondered if it's if there's more development of long-acting local anesthetics for the type of nerve blocks that you had mentioned.
So generally speaking, we're not talking about nerve blocks. We're talking about orals specifically. And so these would not be physician administered products. They would be rather reimbursed under the prescription drug benefit. But there for sure are still some others that are in development as well. Mhm.
Good questions. And I would say that any of us, if we ask for more information, it would be good not only for the individual member, but to send it to Morgan Hall for policy, just for us to all have.
Happy to.
I'm sure there's a lot that we need. Representative Newton.
Thank you, Madam Chair, and thank you for all the work your 200 different organizations working together is doing. A couple of questions I had. One, I have seen there's a little difference with physician administered. You mentioned ASCs and maybe hospitals. I know the long-acting bupivacaine would be the generic, a long-acting, basically like a lidocaine for the lay people that can last up to 72 hours allegedly. And I had a family member who had hip surgery that got that, and it was pretty impressive. Right. Of course, 3 days later, you realized, but hopefully by then some of the healing has started, and so I think that was a great thing. And from what I see, it is a lot more expensive than the alternative. And I would hope that would be one of the things, but that would be administered, I guess, under Medicare Part A, which is the
Part B, sir,
or Part B by the physicians. Okay, that would be for if it was in the hospital. Hospital-based surgery, I didn't know which one that would come under, but that's different than an outpatient prescription, which, as you mentioned, is under Part D.
For sure. So, the Part B benefit would obviously cover the outpatient surgical procedure. And so whether that's done at the hospital or the ASC. And so the problem is that, as well, we give, just for illustration purposes, we give $5,000 to the procedure, or to the facility, I should say. And that's to cover the cost of the surgeon, the anesthesiologist, the nurses, as well as any surgical supplies. In the case of the nerve block, oftentimes that nerve block is counted as a surgical supply, and as such comes out of that $5,000 payment. So what the No Pain Act was intended to do was to say that $5,000 payment, which would come out of Medicare Part B, you would get that full $5,000 payment, but on top of that, whatever the cost of the administration of the non-opioid option, you would get reimbursed for to make you whole, just as has been happening in the ASC since 2019.
That's excellent. One question about the Medicare grouping. When you talk about the number of prescriptions and all, and them going on one group that went up, I guess by payer at least. I'm sure the population has gone up too.
Yeah, for sure.
But has anybody looked at whether that's? I mean, a lot of people are on disability, and they eventually qualify for Medicaid, and some of that may be related to conditions that include chronic pain, as opposed to somebody over 65 who just has to have surgery, orthopedic surgery or something else. Have you looked at the grouping to see is the opioid use disorder in the SSI, the disability side, or is it in the?
So when we did our analysis, specifically on the economic side, we just looked at Medicare. And so we just looked at the cost to Medicare specifically. I will say in terms of rates of opioid prescription, you're exactly right. We have an aging population, and we know that, listen, if you're 65 or over, you're on Medicare, you fall more. You are a more intensive healthcare utilizer. And so you're in the doctor's office more frequently. You hurt yourself, you have more imaging, you have more surgical procedures, for example. And so we understand why that might be higher, particularly as we have more of our boomers age into the Medicare population. As we look at Medicaid, we have not, to be honest with you, we're a national organization, so we haven't done as much work at the very specific state level. And I think we're open to. I think as of right now, we're hoping just to be resources and share some of our learnings as we found at the national level, to the extent that they can be helpful at the state level, just as I think states can be laboratories for innovation at the federal level, as we're seeing particularly on the Part D side, as we start to see some of the states take action to make sure that individuals at the pharmacy counter can access a non-opioid just as easily as they can access an opioid. And so for us, I think we are hopeful that some of the learnings that we've taken from the federal level can be instructive to the state level and vice versa, that we can take some of the learnings that we have at the state level and take them to the federal level, because we are advancing federal legislation now. It's called the Alternatives to Pain Act, Alternatives to Prevent Addiction in the Nation Act, that would do just that. It would say that if you are a Medicare Part D beneficiary and you want to access a non-addictive approach, that you must have equal access to that as you would to a prescription opioid, without onerous cost-sharing obligations on you or without excessive utilization management practices. And so we're working on that at both the state and the federal level in hopes that we put all these options on the table, whether it's acupuncture, whether it's, an opioid, or whether it's a non-opioid. Put it all on the table. Let's facilitate the conversation between the providers and the patient, and let's let them figure it out.
Thank you.
Jump over here just a minute. So Dr. O, you came, I'm not even gonna try to say your name. If you would introduce yourself to the group too and make sure we.
Sorry, I was late. I
No,
got
you're fine. You're
super
fine.
lost and and traffic. Dr. Scoey, I did anesthesia residency, did a pain fellowship at Emory, own probably the largest orthopedic by real estate group in the country. So I have a little bit of experience in this space, actually a lot of experience in this space. Actually, interestingly enough, when we started that practice about 14 years ago, one of the cruxes of the practice was that we're not going to prescribe opiates, and we're going to use alternatives to opiates for every single patient that we can. Obviously, surgical stuff, you're going to run into issues where you have to use opiates to some degree. And we're successful. And actually, Georgia really helped us when they passed the Georgia Pain Act, because it gave us something that we could lean on to say, hey, we're not allowed to do this. You have to have all these different layers of things to be able to prescribe. And, it was hard to start a practice that way, because primary care people want to send you patients they don't want to deal with. And typically it's all their pain patients, right? And they want to line up. I mean, you want to open a pain practice where you give narcotics, you would instantly be busy. You'd have patients down the hall, down the street, be extremely busy. But to have a practice where you're like, I'm not going to do that. It was very hard.
Yeah.
Because, patients didn't want to come back, right? They're going to go shop. We call doctor shopping.
Yeah, for sure.
So anyway, that's sort of my experience in the space, but I had some questions for you, and I
Of course.
appreciate what you guys are doing. I think it's very cool. But I sort of had some questions. One was, so obviously you have to fix the problem, but there's multimodal, right? Like you said, financially, there's issues. One is education, access, all that sort of stuff. So let's start with, for instance, educating the providers. How do you guys go about, or how do you foresee yourself going about educating providers and saying, hey, because I think a lot of them just don't know, like you said.
That's exactly right. And I'm sorry, I didn't catch your last name. So
Scoey?
Escoe. So, we've actually had similar experiences, with some of our clinicians to you, who have actually found that your same experience to be true, but also the opposite to be true, that some of those practices that have been opioid sparing have found themselves to be at a competitive advantage to some of their peers. And so it's interesting to hear sort of both sides of that story. But on the provider education piece, there are agencies in the federal government who have vast experience in doing this. The Centers for Disease Control and Prevention has a very specific program and an opioid stewardship program that is trained just to do some of this education and awareness. We are working with some champions on Capitol Hill to try to appropriate some funding, federal funding, to make sure that some of these campaigns are existing, whether that's at SAMHSA, whether it's at NIDA, whether it's at CDC or elsewhere. I think we're a little, again, I don't really care where it happens. I think we just need to know that it needs to happen. But I think it's not going to happen without some federal investment in this. And given the federal investment to date in not just the opioid epidemic, I think it's really a drop in the bucket. We're not talking about huge amounts of dollars to try to put together a couple public education campaigns, whether that's focused at the provider level or at the individual level. Specifically, one of the pieces of legislation that Congress may take up before the end of the year is the reauthorization of the Support Act. The previous iteration of the Support Act allocated and authorized some dollars to deal with some outlier prescribers of opioids. Of that, only a fraction of those dollars were actually spent. And so we're working with members of Congress to see if we can reallocate potentially some of those dollars for these purposes. But we have a ways to go. And, obviously, the session in Congress is coming closer to an end, and it's going to be, especially in a shortened year with an election.
Yeah, and I think a lot of times, especially on the entrepreneurial brain, why not try to figure out a way where the government doesn't have to pay for it? obviously, you know, there's revenue that comes from the hospitals, there's revenue these practices are making, that sort of stuff, where you make it a requirement to get your license. You have to do this education for whatever. And I've seen it actually with the CME that we're getting every year. I'm seeing a lot more opiate education, which is really nice. But sometimes I feel like if you just make it a requirement, and you know, the hospital has to train their staff if they're going to do surgery, that, you know, you need to do this. This is part of something.
For sure.
It's super cheap. I mean, it's not like crazy expensive to teach somebody something for an hour.
I can't imagine it would be. Yeah, but the focus of our organization is really on federal and policy change. And so because that's not really a hook for federal policy change, you know, again, we try to focus our efforts on what we can do in U.S. Congress rather than individual hospital systems. That said, you know, we are eager to partner with those hospital systems in Georgia and across that would be interested in sort of ringing the bell on this policy change that's coming. You know, if there are opportunities to, you know, host events or do any type of programming with them about this policy change, or about the effectiveness or the ability to utilize non-addicted pain management approaches, I think we'd be welcome. You know, we'd welcome it with open arms.
Another question. So I think the best way to train people sometimes is carrot and stick model, right? So I think you were talking about the carrot, which was basically helping make whole for situations where financially, now that brings its own issues because all non-opioid treatments are not financially equal, right? You know, doing a block may cost a certain amount of resources, a certain amount of time, bill a certain amount, versus giving out gabapentin, for instance, which is very inexpensive, doesn't take time. The guy doesn't have to go and actually set up a tray and do all the stuff. So term non-opioid is just so encompassing that it's hard to talk about it as just one thing. But so the financial model, I like that you're like, hey, let's try to make you whole, even though I think there should be limitations, because, you know, if something's super expensive, like, hey, I don't want to give him, you know, put him on a Demerol or something, but I am going to go do this block that I'm going to bill $10,000 for. I'm just using crazy numbers. That's not necessarily true, but you know, we got to be careful of that because we don't want to abuse the system. But also, how are we going about, you know, with the stick model, how are we going about these hyper prescribers? Because there are some out there. We know them in the community. I remember when I was a resident, it'd be like, okay, here we go. Here's from this doctor who we know. We called it Nitro, the Nitro doc. It would be the guy who writes thousands of narcotic pills, and their patients would end up in our surgery centers or end up in our clinics. And we had to deal with it. Like, this guy's on boatloads of, you know, whatever drug, pick it. And we have to sort of deal with that once they're inpatient or they try to become our patient, that sort of thing.
Yeah, for sure. On the downward prices in terms of the separate payments or the carrot, as you described it, you know, the legislation did include a cap on the amount of the separate payment. So it wasn't just that it would be a blank check for the separate payment for, you know, any existing or new sort of nerve block or any other surgical supply that would come there. So it included a cap at 18% of the covered surgical procedure. And so if you have $1,000 procedure, the amount of the separate payment couldn't be more than $180, for example. And that was particularly to address the concern that you have, that we're not just writing blank checks for super high cost medications in here, that, you know, we do have reasonable checks and balances there. On the hyper prescribers, I will say that, you know, generally speaking, I mentioned the bipartisan support that the No Pain Act had with 175 members of Congress. It was right down the middle in the Senate. And anytime you start talking about punitive measures, it gets tricky in terms of your support from not just on the Hill in terms of members of Congress and their support for the legislation, but also some of the support that we enjoyed from some of the clinical societies that also supported this legislation. When you start telling them what they can and can't do, it gets tricky. I will say, again, in addition to the support the No Pain Act enjoyed on the Hill, it enjoyed universal support off the Hill from patient, provider, clinical societies, and others. And I suspect that if we went down that stick type approach, we would not have such support for it.
And you're only dealing with acute pain, or are you dealing with also
acute pain is our universe?
You're not worried about the chronic pain abuse.
And say I'm not worried about it. I said, you know, our work, our slice of the pie is limited to the acute pain universe. We're trying to pick off the low hanging fruit where we can and not boil the ocean.
Understood. Well, thank you.
Yep, of course. Thank you.
Mr. Weatherington.
Thank you, Madam Chair. Thank you, Mr. Fox, for your presentation. If you would, could you delve a little bit more into the nitty gritty on the trend in Medicare and why it's been such an outlier in growth in terms of its relative share of the opioid dispensing and prescribing, despite your success in the ASC market? And then second, you know, we're interested in, there's definitely, not only is it the right thing to do for the patients, but there is a value prospect in it for payers as well. We would call this value-based care. Can you kind of translate that Medicare policy into what that would look like in a value-based payment for a commercial plan, for example?
Sure. So in terms of the Medicare payment, or the Medicare trends, I think what, we have seen is that there are some, challenges to the Medicare market in terms of budgetary constraints that we know well about. And so by and large, as you know well, prescription opioids are all available right now in generic form. We talk about some of the brand name products that almost are never prescribed these days, just because they're all available in generic form. And so for sure, cost is a consideration there in terms of, the preference to utilize low cost over higher cost. I think generally speaking, this issue gets at sort of the challenge in our healthcare system, and that we value a couple things, and sometimes they come at odds with one another. First, we value quality, right? And the other thing is we value cost. And when it comes to quality, we know what quality pain care looks like. And, Dr. Wong, you talked about what pain care in the United States looks like versus what it looks like overseas, particularly in the EU, where they use far fewer opioids. When it comes to pain care in the United States, quality and cost sort of come at odds when it comes to pain care, in that the lowest cost option is the prescription generic opioid, unfortunately, which are still seen in many circumstances to be sort of the gold standard in terms of quality, in terms of the effectiveness of the pain approach. And so when it comes to Medicare, I think there are a couple things at play. A, you have a sheer numbers game in that you have more patients aging into the Medicare system over the most recent years. B, you have some of those cost considerations that, again, because they are so cheap, they enjoy fairly universal coverage. And then I would say the challenge that we have in translating that across is that we don't have universal coverage for them across Medicare, even despite the ASC policy change. There are some individual payers, as I'm sure you know, that have done better in terms of making available non-opioids versus others. There are, I understand, even apps that have said, before you undergo a surgery, you can take a look at your payer's app to see if they will prescribe you an opioid or a non-opioid. And so as we look across what's happened at the ASC, it took us a long time to make that policy change over the hospital setting. Frankly, we're still not there yet. And I think we're looking over our shoulder to see exactly what might be forthcoming. Like I said, we have been working with some of the national payers about what we hope they will do in terms of following Medicare's suit there. But when it comes to quality-based care and pain care, it's tricky because I think that there are still some that hold prescription opioids up as the gold standard, despite some of the evidence to the contrary that has been cited by not just the CDC and their opioid prescribing guidelines, but other research. And so I think we still have a way to go. I think education is a long way to get us there too. I know we have some of the anecdotes that have been shared here today. And so I think with time, we'll start to see some of these more clinical practices change. We're aware that some of the training in terms of non-opioid based training for physicians and anesthesiologists and others is starting to change, which is great. I think the volume of evidence that we continue to receive in terms of the effectiveness of non-opioids is growing, not diminishing. And so I think in some instances, it's a matter of when, not if, we start to see some of those changes.
Thank you.
Dr. Wong.
Yes, thank you, Madam Chair. Thanks, Mr. Fox, for the presentation. And I think that last question and answer partially answered it. But, when you look at what Dr. Askewy and Mr. Wethington commented on, a lot of these patients that get referred into that surgical setting or to the surgical person is from a primary care doctor who's written these prescriptions. So I think the outpatient clinic setting with non-surgical aging patients and chronically ill patients is why that Medicare, I'm presuming, is not going down, but actually going up, the number of prescriptions being made. You kind of partially answered that, but do we know when that will be addressed? Because I guarantee you there's many more prescriptions written in that setting versus the ambulatory surgery or surgical setting. And those patients are being referred in potentially already on opioids, et cetera. And that to me is, an area maybe they should have started with at that point.
Yeah. So the limitation of this slide, while I confess it is one of my favorite ones, is that it only goes to 2019. But the benefit of this is this came from a presentation that CMS gave themselves. And so this is IQVIA data straight from CMS's own mouths. If you push this out a little bit, we do know what opioid prescriptions look like through 2023. It's about 132 million and change. And so if you pushed it out to 2023, you would see that in terms of the overall trend of opioid prescriptions since 2011, we're down about 50%. However, from my organization's perspective, again, I don't have those fancy letters after my name. I speak to a lot of clinicians about their experiences and what's needed. Our purview in this is really the acute pain universe and what we can do, not necessarily in the chronic or in the primary care space, but what we can do to prevent those individuals who are exposed to an opioid, potentially, or who are given an opioid prescription, whether they, that they may not have wanted, and how we can prevent them potentially from developing an opioid use disorder. That's really our purview.
Right. But doesn't acute pain happen in the outpatient setting?
For sure. And I think that's, when we start talking about the change we made in the No Pain Act, that was specifically what we were aimed at, is the outpatient surgical setting.
Got it. Okay. And then the other question I had was around, in acute pain, the benefit of using physical therapy, rehab, OT, also behavioral health.
Yeah.
And in this country, we have lacked and taken away more and more resources for behavioral health. I think we learned a lesson during this pandemic and kind of where we are now. There's not enough and everything's gone virtual. But having said that, can you describe a little bit about what some of those opportunities are? And, we focused here on the non-opioid medications, but for some of these other areas, what are we doing to kind of push that agenda?
Of course. And so when we were crafting the legislation, that the Non-Opioids Prevent Addiction in the Nation Act, we had to very carefully define a clinical standard for what qualified as a non-opioid product. And we created basically a twofold standard for a drug and for a device. And the standards were a little bit different. For a drug, the clinical standard was that it could not act on the body's opioid receptors, right? So we don't want to replace one addictive product for another. It also had to be FDA approved to be deemed safe and effective. And it also had to have an indication for post-surgical analgesic support. So if you want to be qualified as a non-opioid drug eligible for separate payment under the No Pain Act, you had to check those boxes. If you wanted to be a qualifying device under the No Pain Act, the threshold was slightly different. You had to demonstrate the ability to reduce or obviate opioid consumption post-surgically as evidenced in a peer-reviewed journal. You didn't have to have the indication standard, but you did have to have an approval for use in general analgesic support, not necessarily for post-surgical, but for general analgesic support, just because there weren't that many products in that space, as well as you had to be deemed to be safe and effective. And so when we were putting the No Pain Act together, we asked for the evidence base for some of these other therapeutic services like acupuncture, physical therapy, chiropractic services to show us, like, do you have evidence that you can reduce post-surgical opioid consumption or post-surgical opioid prescribing? And we were unable to really substantiate a lot of it. And so what we did instead was included in the No Pain Act. Also, it doesn't get as many sort of news headlines as sort of the policy change, but was a study that's going to be conducted by Congress that's going to look into the ability of what we call these other therapeutic services in providing effective acute pain relief services, and put out a report to Congress on the barriers to access for these services. And that report will come out likely 18 months after the effective date of the act, which would be January 1st, 2025. So again, it's not that it's not interesting to us. It's just we need a little bit more work building up the evidence base on the efficacy and what the associated reductions on opioid consumption are.
Thank you.
Chairman Hawkins.
Very impressive presentation, to tell you. Well, the good news, probably the old news is, back at Emory, in the 70s, they trained us in the prevention of pain, primary closure, placing Penrose drains for pressure type things, use of Marcaine rather than lidocaine or addition to, use of Motrin, which is now ibuprofen, along with diphenylhydramine, which is Benadryl, to give them that little drowsy kick. Also, we used to write 12 tabs at Florset, 3 days, and then tell the patient, if you need more than that, something's wrong, I need to see you back. So we did a lot of prevention. I assume they're still doing that in medical school and dental school. But here's where I'm going with this, and the question for you is, a lot of times patients would come in and ask for an opioid. I mean, they would demand an opioid. You'd almost have to throw them out of the office if you didn't write it. So how much are you doing as far as public awareness on this versus professional provider awareness?
It's an extremely important point, and that's why I'm pleased, with our coalition and the umbrella that we get to partner with groups like the Partnership to End Addiction, National Safety Council, and others that have put resources available, things like questions you should ask for before you undergo a surgical procedure. There's more that needs to be done, and again, we are still trying to seek some federal investment in some public service campaigns to talk about this, because again, I know we have sort of a little bit above average, if you will, if I could be modest, sort of healthcare knowledge on this panel up here about what non-opioid pain relief looks like. I will say that by and large, the public does not know. We are conducting public polling constantly about awareness on non-addictive options and patient preferences. We'll have something out probably in the next month or two about exactly what public attitudes are about non-opioids versus opioids, as well as awareness about this. But we know we need to do more. If you were to do focus groups, I suspect you would find that by and large, patients don't know that there is a non-addictive option to the opioid, and all they know is the opioid. Again, I talked about my old school. I came from the school of stay ahead of the medicine. I also remember when I had my wisdom teeth out, my mother told me, we're taking you to the good doc who's got the good stuff, and that meant the good pain pills. And again, this was a different generation, but we know better now, right? And so we know we still have to do better. And again, we know we're going to need some federal investment to do better.
I think the state of Georgia has done a very good job in this area. We can no longer call those drugs in, and they must be written prescription. And for our license to be renewed biennially, we take an hour or two course every 2 years on opioid addiction and prescription. So I think we're moving in the right place. I would like to see a whole lot more on the public side if we have that opportunity as far as education.
I agree. And I look forward to partnering with you, the state of Georgia, and the rest of the country to do better. Because again, our work doesn't stop until everybody knows about it. Everybody has that choice. Again, it's not about, with all due respect, it's not about mandates. It's not about carrots or sticks. It's about choices. And let's put everything on the table and let providers and patients figure out what makes sense for them. Correct. But right now, unfortunately, there are some things in the way, whether that is, at the facility level, at the payer level, or whatever. And we're just trying to work to remove those barriers so that we can get to a better place.
Thank you.
Thank you. Representative Gladney. Punch your button. Let's see if we've got you. Now try it. Sorry. We're going to take the volume up. Try it again. There we go. I think we've got you.
Try the one beside you.
There.
That's it.
There we
Okay.
go.
Thank you, Madam Chairwoman. Mr. Fox, thank you very much for your presentation. When the discussion was had about the Medicare costs and the variations, is it possible that the increase for that particular category could be influenced by VA patients who are accessing their Medicare resources outside of VA benefits, because some of these drugs are not in formulary? And if in fact they are, is there a way that we're tracking those uses for the sake of understanding the trends of this crisis and moving forward to be more effectively applying those dollars?
I'm sorry, I'm not sure I fully understand the question. Are you wondering if the projection in terms of the economic cost to Medicare considered those who might be, have VA as well as Medicare?
Yes, sir.
So the economic analysis looked at Medicare's claims data. And so it would denote if you were a Medicare beneficiary and you had an OUD diagnosis. It did not look at if they also had a secondary insurance program. And so the analysis did not potentially look at, what we're seeing in terms of those who might be on VA as well as Medicare, but simply said that if you are a Medicare beneficiary and you received, a diagnosis for an OUD, what that diagnosis added to your annual bill to Medicare. Does that
And
answer your
so
question?
VA patients could be doing both in some categories. Is that correct?
I think it just depends on the extent of your injury, as I understand VA healthcare. And so whether that injury was sustained while you were serving or not. And so it would really depend on exactly what the procedure was and exactly who was paying for your procedure.
Okay. Thank you very much for that.
We're going to hear a question from Mr. Breedlove too, who's joining us online now.
Thank you, Madam Chair. And Mr. Fox, thank you for your presentation. It has been fascinating, and I'm
Mr.
very
Breedlove,
much appreciative. Can you not hear me, Madam Chair?
let's see. There, Mr. Breedlove,
Yes, ma'am. Can you hear me?
there we go. We're ready
Yes,
for your
ma'am.
question.
Thank you, Madam Chair. So I'll say, Mr. Fox, thank you for your presentation. It has been informative and enlightening. Also want to thank you and the Umbrella Organization for all the work you do, especially my friends at the Partnership to End Addiction. As somebody who worked on Capitol Hill for several members, I appreciate the work you do up there. And I'm wondering, and I'm trying to phrase this in a way you feel comfortable answering it publicly. Within our delegation from Georgia, has there been a member or two or three that has emerged as a good partner, a champion that you might share with us? And then outside the members of Congress, as a follow-up question, are there some organizations kind of maybe that don't see the world the same way we do in terms of supporting this concept? Any folks working against this concept philosophically, and who maybe what members might be supported from our own state?
So thank you for the question. I'm going to put my politician's hat on and say that I have been very happy and blessed and pleased to work with the entirety of the Georgia delegation and have enjoyed a lot of success across both Democrats and Republicans from the great state of Georgia. We hope to continue that tradition with the No Pain Act and including with the Alternatives to Pain Act that we're pushing now. As of right now, we don't have a whole lot of support from the Georgia delegation on that piece of federal legislation. Hopefully that will change soon. It was just introduced this year, but we continue to work with them. And in terms of, what detractors we face, I think we didn't get a whole lot of detractors in our work. I think the only sort of questions that we get about our work and about our mission is what implications our work might have for those who have a medical need for prescription opioids. And I say again, and I've said it here, I think at least twice, I'll say it for the third time, nothing that we do is intended to dictate clinical practice. I am not in any way, shape, or form trying to get in the way of any patient and their doctor in terms of what medications they need or they're given or they might not be given. Those decisions are strictly for the patient and the doctor. And this includes chronic pain patients or patients who are in daily intractable pain. Nothing I do is intended to restrict their ability to obtain their medically necessary medications. All we're trying to do is we're trying to promote choice and promote an even playing field when it comes to pain management. Put everything on an even playing field from a reimbursement perspective, from an awareness perspective, and let those in charge figure it out. And those in charge should be either yourself, a family member, a caregiver, or your healthcare provider. And so I will fight until I'm blue in the face to make sure that that choice exists. And that choice exists uniformly across care settings, whether you're in the hospital, whether you're in the outpatient setting, whether you're at the pharmacy counter, wherever, you should have access to choice. And that choice can come in the form of strictly access. It can also come in the form of cost. We don't think you should make different choices based on what they might charge you for an opioid versus a non-opioid. And so we're seeking a true level playing field. If you want that generic opioid, it should be, the same price that you would pay out of pocket potentially for a non-opioid. Let's make it true choice and what makes sense for people. And patients should not have to say, well, if I want that generic opioid, that might be, again, just for illustration purposes, that might be $10. But if you want the non-opioid, that will be $50. We don't think that choice should have to be made. True parity, a true even playing field, means that patients have equal access at equal cost to medications that they choose. I'm sorry, I hope that answered your question.
No, thank you, sir. Thank you very much. That last point was very well taken. Thank you.
Representative Al.
Thank you. I just wanted to build off something that Dr. Hawkins mentioned with respect to opioid risk mitigation and prescribing patterns. And one thing that I think we want to do as we move through these series of meetings for the study committee is obviously to guide development of policy and legislative action as we, there's not every problem has a legislative solution specifically, but I think there's some things that we do that can help mitigate risk. one thing that I want to bring up was that this past session, we actually did end up passing a bill, at least out of the House, that I worry exacerbates some of this problem with respect to prescribing patterns. And you guys might remember this with respect to loosening the ability for mid-level providers, APPs, to prescribe Schedule II narcotics. And this was couched in the framework of having a rural healthcare shortage and not having enough providers in these areas, and allowing mid-level providers to provide, was it 3 or 5 days of schedules for narcotics for patients in need, maybe over a weekend when they couldn't get in with their practitioner. Based on what we've heard and based on, research that has been done on the issue, obviously we know that it does not take 3 or 5 days to increase your risk for opioid dependence, right? So we know that. That's the first thing. The second thing is, I can say as a practitioner, and we all know this, that the easiest thing in the world to do is to write a prescription. Like it just is, right? We know that patients come in. We know that patients, as Dr. Hawkins said, sometimes come in wanting or demanding pain medications. And the easiest thing to do is just to do it, right? So I think moving forward, when we look at things through this lens of opioid risk mitigation, that we make sure that we're not exacerbating the problem in service of what we view as another problem in the state, right? Did that bill pass ultimately on the Senate side? Did. Yeah, so that's something that worries me as we talk about this, because the last thing we need, honestly, is more people writing opioid prescriptions, particularly, if I may say, in rural areas where this epidemic can tend to be worse.
Thank you for bringing that back to our attention. Chairman Newton.
Just really also following up on something Chairman Hawkins said about sometimes it's a stair-stepped approach. Maybe it's prescriptions that you don't have to fill. I think he mentioned maybe public awareness. I know we've had education. Of course, I trained during the time when they came out with pain as the 5th vital sign after, temperature, pulse, respiration, and oxygen level. And I still remember in the ER, a patient walking me over to a poster on the wall behind glass that pointed to number 9 that said, "I have the right to have my pain treated." And I said, I've got 2,000 medicines in the PDR. There's just 4 I can't give you. Yeah, but they didn't like that. I can tell you if they had read that, it was too late. So I do know that education for providers is helpful. And sometimes, and a lot of what we do in acute pain is we start with acetaminophen or ice, frankly, and then acetaminophen, and then Motrin or naproxen. And then it is helpful. I mean, I've had family members with surgery and broken bones, a shoulder fracture in our family, rib fractures, both that can't be immobilized in a cast. And so they're going to move. And I kind of have wondered if we've gone almost too far. We've got multiple trauma patients with multiple broken bones that go home with a recommendation to take Tylenol. And, after having a wife who slept on the sofa for a while with a shoulder fracture from running with our dog, it's kind of like, could we go too far? And I know the pain management physician, Dr. Armin, mentioned they don't want to prescribe narcotics. Well, there's a lot of people from those early 2000s and mid 2010s that got addicted, maybe due to true pain. And now they're addicted. We have shut the spigot off, if you will, of legal, safe supply of medications for people who were iatrogenically either wrongly or rightly addicted. And now I think that's the ones who, I know we call it overdoses or opioid overdoses, but a lot of those I think we've talked about are maybe fentanyl poisonings just because of the irregularity of the fentanyl micrograms that are in an alleged fake Percocet or whatever. I don't know. Did we not do enough once they got on these medicines? And once again, 90% do fine according to your stats. They can get treatment and surgery with opioids or dental surgery or multiple fractures and do fine. I don't know. Do we need to have more options for people to gradually get off these? I mean, because if the pain management, our thing in the ER is, well, if you want that refill, you're going to have to go to pain management. But then the pain management doctors don't really want to, they don't want to be the hyper prescriber that has a spotlight on them either. And how do we take care of the ones that we've created through through an earlier government intervention on, I know we were measured in the ER, arrival time to pain treatment on long bone fractures. But of course, they wanted us to get it done in 15 minutes. We couldn't get the x-ray back in 15 minutes. So we had to give it to everybody with an extremity injury for fear of having a legitimate tibia fracture that didn't get pain medicine within the 30-minute target time. So some public policies we've fixed, PDMP, for example, the drug monitoring program, where it's synced with our EMRs to automatically check somebody's record. Did they get prescriptions down the road or whatever? Do we need to do more to undo what government did in the past by encouraging rapid and almost indiscriminate treatment for pain? Now people, the 10% have gotten addicted. What do we need to do? Or do you deal with that? I know that you mentioned your acute pain and not necessarily chronic. And so these are maybe addictions that started with acute pain treatment.
It's true. There are a lot of chronic pain patients that started with an acute pain instant, right? Like
you mentioned a couple,
sure. Somebody, pain in the house, falls off the ladder, has a back surgery, gets prescribed, and then all of a sudden they have chronic back pain. It does happen. There for sure is a link between acute pain and chronic pain that I think we have to be cognizant of. And I think that's why it's all the more important that we get right at the jump, what the opportunity is in non-addictive pain management options. And we need to better understand, I think, the individuals who are at risk. There's been a lot of investment in some of these technologies and algorithms and such to try to identify those patients who are most at risk for developing that OUD, right? Unfortunately, the Food and Drug Administration hasn't really fallen in love, I think, with a lot of them. And so that there still is an ongoing need to help us better identify what risk looks like. Are you at risk if, for instance, you have an extra glass of wine with dinner, for example? Are you at risk if you have a family history? I think we would all agree there, right? What exactly does a risk profile look like, and how can we better, there's been some research into genes, like, can your genes be predictive of exactly, are you sort of more at risk than some others because of your genetic makeup? I think we still have work to do there. I will also say that, we don't dictate clinical practice. And so if you come in and, how you are treated, that's up to you and your doctor, whether that's a primary care, whether that's an emergency department physician or whomever. You're exactly right that we still do need a lot of education, but I would say that education without access is worthless. That if we educate about non-opioids, we can talk and we can educate until we're blue in the face, but what good does it do if at the end of the day that patient can't go to their doctor or their healthcare provider and say, I want this? And so the two really do go hand in glove, that we can't educate unless there's access. And the two really do need to go together because otherwise you just have a whole lot of smart people who are asking for things that they can't get. And so I think for us, we need to make sure that we're doing both at the same time. And you're right in terms of what the research says. 10% might not sound like a lot in terms of, those individuals who might develop an opioid dependency or an opioid use or disorder. But I'm not taking a 10% chance with my son. I suspect others wouldn't take a 10% chance with theirs. And so it might not sound like a lot, but it's still potentially 5 million Americans every year who are newly on the rolls of, additional healthcare costs potentially, or on the path towards a sort of pattern that could take them, to the streets. And so for us, we know where it can start, not necessarily that it always does, but we know where it can start. And when I talk about low-hanging fruit, it's a challenge we think we can solve for. And so doing the education as well as ensuring the access are paramount important to us. And again, we will leave it to those with those fancy letters after their names to figure out how to take care of the patients. We'll just make sure they have all the tools they need to do it.
I appreciate that. And I do know that government spotlights is a very powerful tool. I know you say you don't want to dictate, and they never dictated exactly what I would write, or I was medical director for over 12 others at the time too. The spotlight of government can be an effective tool. We need to make sure that, maybe we first do no harm. Maybe we should have done back in the early 2000s, but it would be interesting to see if we could come up with a way to use that transparency, if you will, or government attention. Even reporting can be an effective way to ensure that people at least know about the alternatives.
For sure. Well,
thank you.
We stand ready to partner with you guys to get that message out and make sure that people know, because we're happy to do it.
Thank you. Ms. Payton.
Thank you so much for your presentation. Something that you said that really stuck out to me was when you were speaking of your colleague's son, is how he said, "This is the first time I feel normal." And I think that's a really important point to bring up, that for many people, the use of opiates is the solution to their problem rather than their problem. So, and you may have touched on this, but this 10%, is there any additional data to understand this 10% demographic data, pre-existing conditions that may exist that is making their risk factors higher to develop a dependency than the remaining 90%?
Sure. So that is a number I confess it came out about 2 weeks ago. I have not dove deeper into that number. Usually we present it as a range, and the range is done by procedure. And so I usually present that number as a range from 6 to 20%. But that range I also talk about usually is about opioid misuse rather than opioid dependence or opioid use disorder. And so what happens essentially is a health system will do a look at long-term opioid use after total knee arthroplasty, for example, and they'll put that number out. Or another one will do it over, after, gynecological surgeries, for example. And that's how we get those ranges. But the most recent one was more robust in terms of broad application across different surgeries. And because it took that additional threshold in terms of the dependence in the opioid use disorder, that's one that we were very interested in. But I will note that, obviously this opioid epidemic has been one that hasn't discriminated. We have across races, gender, socioeconomic class, we have all that are impacted. You have an interesting dynamic when it comes to Black Americans who are chronically undertreated for pain in this country. And yet we have others who traditionally to be middle class or upper middle class, white Americans who potentially could have developed an order. And I think traditionally that's how we've thought about this disease, right? It is sort of that type of a disease. But I think all of the evidence that we've seen has shown that this is a disease that doesn't discriminate. It doesn't discriminate against race, gender, or socioeconomic class. And it's a disease that has shown that you can't just throw money at it to solve it. So unfortunately, I don't have any different demographic. I'd love to say that, this is happening more in this generation or this other generation. What we do know is that amongst the fastest growing cohorts of newly persistent opioid users, again, that's another one of those catchphrases that has a very specific definition to it, which means that they are still taking opioids 3 to 6 months after their acute pain incident. So the fastest growing cohort of newly persistent opioid users is of older Americans.
Thank you.
Mm-hmm.
Well, thank you. That's the end of the questions that I see here right now. I want to thank y'all. It was a great discussion, wonderful questions, wonderful presentation. You've started us on the road, I think, of a great process of discovery that is going to be very exciting. So I thank y'all for your interest and for your focus here. Each of you are very important to this discussion that lies ahead. Mr. Fox, we really appreciate you being here and
Thank you so
starting us
much.
off.
Thank you for having me. Thank you.
Yeah. So what we're going to do right now is the committee will recess. We're going to go have lunch right across the hall, members. And then we'll be back in here at 12:30 to hear more from some of our agency and other partners in our statewide effort to look at this. So we will be back soon. Thank you. All right, y'all, we'll start getting ready to start again.
Tuesday, our high is gonna be 74, Wednesday 69.
All right, good afternoon. It's great lunch. Good to spend a little time with everybody. Okay, so we are going to come back to order here. And our first speaker is Dr. Chris Rustin, the Deputy Commissioner for our Department of Public Health. We had the privilege of working together on another study committee that brought forth some good things. I'm hoping that this one will also do the same thing. Dr. Rustin, if there's anything you'd like to tell us about yourself before you get started, that would be great. And we'll get your microphone up and going.
This is on, right? Oh, there we go. So first of all, thank you, Chair. It's good to see you again. We definitely worked together on a childhood lead poisoning committee, so I appreciate your leadership on that. My name is Dr. Chris Rustin. I serve as the agency Deputy Commissioner. I've been with the Department of Public Health, working at local health departments, and the department sounds like so my name is Chris Rustin. I serve as the agency Deputy Commissioner. I've worked in local health departments and at the state health department in Georgia for January roughly makes 25 years. Most of my career has been in public health in Georgia. And I've worked in a variety of programs from environmental health to overseeing our health protection division to currently serving as the agency Deputy Commissioner under Dr. Toomey. Today, what I'm going to present to you is data from our drug overdose surveillance system. I'm going to present really a global picture of what we're seeing. Some of the information is somewhat reflects what was presented earlier this morning, but very specific to Georgia. I mean, I'm going to talk a little bit about some national rates as well. Next slide. There we go. So our drug surveillance unit, one slide back, please. There we go. Our drug surveillance unit is housed within our epidemiology department. It primarily is funded by federal funds we receive for opioid response. The grant funding that we receive in Georgia is the acronym is OD2A. Overdose Drug to Action is the grant that funds these programs. And this particular program provides a variety of surveillance. We use the data that we collect that I'm going to present on to help respond to any rapid increases or clusters in any type of drug overdose, primarily around opioids in our communities. We fund a position in every public health district in the state. And so every public health district has a public health analyst as their title, but their responsibilities are primarily around prevention education, making sure that partner organizations have access to naloxone, and to sort of serve as a conduit to provide education to the law enforcement community and the responding community if there's ever a cluster or an outbreak of any type of overdoses, primarily around opioids. Starting in 2013, which is where our data really starts, illicit opioids such as heroin and fentanyl drove the sharp increase in opioid overdose deaths in our state. But beginning in 2020, drug overdoses sharply increased due to the increase in fentanyl, illicit fentanyl, and illicit drugs, including stimulants like cocaine and methamphetamines in our state as well. One thing that I do want to highlight is, although I'm presenting on drug surveillance and data, the other side of our opioid program is our prevention side, and that's the side that the goal is for them to provide prevention education. And underneath the prevention unit is our prescription drug monitoring program. And this is obviously a mandate for physicians who are writing certain classes of drugs to enter that information or to check the prescription drug monitoring system before they prescribe those drugs to get kind of a history of that patient. And so we do try to educate on the PDMP side as well as other prevention education out through our health departments. Next slide. One back, please. So our current data, the data from these reports come from a variety of places. The data is somewhat delayed because a lot of this data comes from places like death certificates where we evaluate medical examiner reports. And so it's unfortunately not real-time data. So you'll see that this data is about 1 year to 2 years old, but we derive data from EMS, the EMS agencies, from syndromic surveillance, from syndromes, hospital discharge data, death certificates, our PDMP, prescription drug monitoring. And all of this data is available in very comprehensive reports that you can find on our website. And the link is here that has all these comprehensive reports, from annual surveillance reports, quarterly reports on morbidity and mortality, and various monthly reports. So today I'm going to present a snapshot of what these reports show. But if you would like additional details, we can certainly send those to you, or you can access those through the website. Next slide. So here's sort of a history of the overdose mortality in Georgia that we've seen, and this goes back to around 1999, and we describe this in 3 different waves. The first wave really started with prescription opioids. That's the kind of the first wave where we started seeing more overdose mortalities back in 99. But what you can see from this is the first dark blue line is a combination of all opioid types. And you can see that the second wave was really a rise in heroin in the state. But the third wave, which is where we are now, is, and you can see these absolute sharp increases, is driven by the illicit fentanyl and other illicit drugs in the state that's causing these overdose deaths. Heroin's on the decline, at least in the data we're seeing now, and deaths from commonly prescribed opioids is on the decline, but those sharp increases is driven by illicit drugs. Next slide. Delving into this just a little bit deeper, if you break this out by drug class, again, the top line is all drugs combined. It's really any drug. That includes prescription opioid pain relievers, includes opioids used to treat addiction like methadone, but it also includes illicit drugs, heroin, synthetic opioids, illicit fentanyl, or illicit manufactured drugs like fentanyl. But as you move down, really the take-home message, I think, on this slide is a couple of things. Is at the very bottom is our prescribed drugs. These are your typical prescriptions that we see, like hydrocodone, oxycodone, morphine, or opioids like methadone that's used to treat addiction. Those numbers are declining, and throughout this presentation, we're noticing trends in those rates declining over time. But again, and this will be the take-home message, we continue to see a rise in these numbers from the illicit sources that are out there. And some of the illicit sources are prescription drugs that get sold illicitly or get sold to others to be used. And so some of those could be prescription drugs that are sold or manufactured illicitly. Next slide. Looking at data sort of geographically, what this slide shows is opioid-involved overdose emergency department visits. This is 2023 data. And just to make this simple, the darker the colors means the more ED visits in those counties. And then you can see that around the more populous counties, you're certainly going to see more people that potentially overdose and show up in the ED. But you can definitely see this large grouping of red counties around the metro area and moving out west and up into the northwest area of the state. Next slide. Breaking this down even more into quarterly data, this is the last quarter of 2023. So it's similar to the slide before, it's just showing a different view. We do note that there's a drop in both opioid and stimulant overdose ED visits in the third quarter. And this is also consistent later in my presentation on some EMS data that I'm going to present. But hopefully these trends that we're seeing will continue. As more and more data becomes available, we'll continue these graphs out and publish these particular reports. Next slide. Suitors is our system that we use to collect all of this surveillance data. It stands for the State Unintentional Drug Overdose Reporting System. This is a system that pretty much all states use that receive funding to track and conduct surveillance on opioid response. It includes the unintentional opioid-involved overdose deaths. We have reports from 2017 to 2020. It has information on our demographics in the state, risk factors, and again, a lot of this data is from death certificates, the coroner medical examiner reports. There's toxicology data that's in this report, EMS data, as well as information from our prescription drug monitoring program. And I've got a few slides that I'm going to just show that just kind of give you a snapshot, because this is a very comprehensive report that's available. Next slide. So what this slide breaks down is the percentage of overdose deaths by drug class. And the very first bar graph is all opioids combined. But when you start looking at the different types of drugs, you see the second one is illegally made fentanyls. Heroin, prescription opioids is relatively small on the graph. Stimulants, anti-stimulant means it's could be prescribed stimulants as well as cocaine or meth. And then you got meths separated out separately, the benzodiazepines, and then your non-opioid sedatives. Again, if you sort of combine a lot of the illicit drugs that are driving this, if you was to put that into one bar graph, it would far out exceed all the other ones combined. But the prescription opioids, we're seeing, again, a smaller number of those being prescribed, smaller number of folks dying from those, but a lot of the deaths are occurring from more of the illicit sources, which could include legally prescribed prescriptions that end up on the black market. Next slide. This is showing the percentage of overdose deaths by most common opioid or stimulant. And it just kind of breaks down. The top, around 22%, is from illegally made fentanyls or other opioids or stimulants. Next is illegally manufactured fentanyls and methamphetamines, and then illegally made fentanyls and cocaine. You see a kind of a theme here. The fentanyl keeps popping up. And as you move down the chart, you end up with meth as well as other opioids and stimulants, and then cocaine and other stimulants. That's sort of the top types of OD deaths. Next slide. These just demonstrate some of the demographics in the state, and really two take-home messages here. Although white males and females have the highest rates of opioid-involved overdose deaths compared to other races, we're seeing a sharp increase in Hispanic males, almost 152% increase from 2017 to 2020, followed by Black males at 111% increase. And, you know, if you look across all the classes here, whether it's white, non-Hispanic, Black, non-Hispanic, or other races, or Hispanic unknown, you can see that those charts typically increase across the board on really all those demographics there. And so that's really, I think, the best take-home message is that we certainly see an issue here and a concern here, and need to work on the way that we're educating our prevention message. The next slide is the top 10 opioids. This compares 2017 to 2020. And as you can see, in 2017, heroin was the number one at the very top, followed by oxycodone and then fentanyl. Compare that to 2020, and it flipped to fentanyl, then followed by heroin and then oxycodone. And so we just kind of flip-flopped over the last 3 or 4 years there. As I anticipate the trends are going to continue as we add newer data to these reports. What this shows is more of a geographical slide. In 2017, there was a variety of different substances that were being found in the toxicology related to opioid deaths. The first, I guess, the graph on or the map on my left-hand side, looking at the screen, you see a variety of different substances found all over the state. This map is broken up by our public health regions, but at that time, the coastal region is where the fentanyl was lighting up, that dark red area. But then there was different substances found in toxicology all over the state. Moved to 2020, and the entire map is almost red, which is fentanyl. And then you see a pocket of heroin and a pocket of fentanyl and heroin in a couple of regions of the state. This just breaks out geographically by county, and that really mimics what we saw earlier. Although counties with the highest population have the highest counts of opioid-involved OD deaths, the highest involved OD deaths are distributed across the state. I mean, we're seeing, and you'll see in a later slide, our EMS data showing that it's from 2017 to 2022, we're seeing more and more EMS runs across the state to really every county in the state. In 2017, 14% of Georgia counties had more than 10 opioid overdoses compared to 19% in 2020. So those, again, numbers continue to increase. The next slide is the toxicological findings. At 91% of opioid-involved overdose deaths, which were driven by fentanyl in Georgia, involved more than one substance. We're seeing more and more what we call polysubstances, where people are consuming or taking different substances at the same time. And this, these types of substances that are shown in this chart are substances that were found when someone is OD'd and on an opioid. This is in addition to an opioid that was found. So you've got cocaine, a lot of the stimulants, antihistamines. There was some gabapentin in there, as well as the benzodiazepines. And then all this really shows, again, is geographically where we're seeing more and more of these polysubstances. The darker the colors means the more substances found in the toxicology. And so the dark reds means there was up to 7 substances found in these overdoses. And you can see there's 2 areas of the state in 2020 that was really bright red. But even the lightest color is 3, at least 3 substances were found in this particular map that I'm showing. And this is based on postmortem toxicology that was done from OD deaths. The last, I think this is sort of the last geographic slide. And what this shows is mapping fentanyl specifically by county from 2020 to 2022. And the map on the left side is just numbers. The map on the right is rates. A lot of the counties could not be calculated due to small numbers. And so that's why there's gray areas on the rates. But mapping the fentanyl-involved overdose deaths really shows a similar pattern to what we're seeing in all the other maps, is that this has spread across our state and into pretty much all of our counties, and is in a lot of cases being driven, again, by those illicit manufactured fentanyls. Next slide. So just a few key findings from our Suitors report based on the data that I presented is that 20% of the opioid-involved overdose decedents had a diagnosed mental health problem at the time of death. Substance use, 88% of opioid-involved overdose deaths had a known substance abuse problem. And as a response to a fatal overdose, 67% of these ODs occurred at the decedent's home, and 57% had a potential bystander present, but only 24% had naloxone on hand. And what these findings reveal, at least for us, is opportunities for future intervention, for more education, especially around naloxone, and having that available, readily available for people to use if they know that there's someone in their family or friends that have a substance use problem, that they could potentially respond to that. The next grouping of slides is data from our prescription drug monitoring program for the physicians in the audience. I'm sure most of you are familiar with this. In 2017, when this law was passed, dispensers were required going back to 2017 to enter prescription information into this particular system for Schedule 2 and higher, or Schedule 2 to 5 controlled substances. And they're supposed to be entered within 24 hours of dispensing. In 2018, prescribers were required to check the PDNP before prescribing Schedule 2 or higher opioids, or Schedule 2 to 5 opioids. Really, the goal of this system is really just to be a tool for prescribers to be able to look up the history of a patient to see if they have been, pill shopping or been to other physicians, and to try to make wise prescribing decisions based on the history of that patient. This particular system is housed within the Department of Public Health and within our opioid response unit. Just a few trends that we've seen, and this data is fairly current. From 2023, we saw improvements in opioid prescribing practices from 2022 to 23, and this is evidenced by these indicators. In 2023, about 6.5 million or 6.3 million prescriptions were written for opioid-related drugs. And so the reason I say that number is because while these percentages look small, they're a percentage of a very large number. From 2022 to 23, the number of opioid prescriptions statewide decreased by 3%. Benzodiazepines decreased by 3%. Stimulants did increase slightly by 1%. From 2022 to 23, the rate of opioid prescriptions dispensed in Georgia decreased by 7% in ages 5 to 54, 7% in ages 55 to 64, 6% in those age groups of 65 to 64, 5%, 75 to 84, and 3% among those 85 and older. And I think this was discussed earlier. You probably see the smaller percentages in that older group due to issues that older population may have, whether it's from chronic conditions or they fall more, they break more bones and those things. But overall, prescriptions have decreased by 4% for both males and females based on our data in our prescription drug monitoring program. This really just demonstrates that while the graph is subtle, you can see a decrease in opioids and benzodiazepines with a slight increase in those stimulants. And these stimulants, could be stimulants like Adderall or Ritalin, things of that sort. This slide shows the number of prescription and drug type by year. And again, it shows the numbers. These are rounded numbers, 6.4 million, 6.6 million. You can see that those numbers have come down from 2020 slightly with that slight increase in the stimulants. Just another way to kind of demonstrate that data looking at numbers. And then the last slide is just male and female. We're seeing a decline in those prescriptions as well, as I stated earlier. Just a graphical description of that. And so, the trends are promising. There was I think some discussion earlier about educating physicians, educating the community as a whole, and we certainly would like to be a part of that. I think that's part of our program. Our opioid response program has a prevention-based side of that. And so however we can help in educating, especially around the prescription drug monitoring program, we're open to ideas in improving that area within our agency. I did want to just briefly mention neonatal abstinence syndrome. I don't have a lot of good recent data on this, and it's something that we've highlighted in our program to start collecting better data on this. But neonatal abstinence syndrome is just drug withdrawal syndromes that results from an abrupt stop or discontinuation of chronic fetal exposure. So essentially, the mother is using some type of drug during pregnancy, and when the baby is born, there's an abrupt stop of that. These substances, again, include opioids, whether it's morphine, methadone, it could be fentanyl, benzodiazepines, barbiturates, and it can include illicit drugs as well, like cocaine or methamphetamines. The next slide is a little bit dated. It's 2017 data, and we're working to pull together some more current data here. But this is just a toxicology screening results from 2017 among those confirmed with neonatal abstinence syndrome. And actually, in this particular data slide, you could see that cannabinoids was the highest number out of this particular group. that tested positive, but also depressants, opioids, as well as stimulants were in that group. And so we hope to have better data collected on this and be able to present. Our EPI team is working on this as we speak to put together better data on this particular syndrome, but I did want to mention that to the group. The last group of slides that I'm going to show is our EMS run data. And if you go to the next slide, what this shows is total overdose. What this shows is essentially our overdose responses, and we are seeing a slight decline as matched some of the other data that I presented in the number of responses. This particular chart shows the number of overdoses compared to fatal overdoses that have been responded to by EMS in the state. And it's 2019 to 2028, and certainly the numbers have increased, but there has been a slight decrease between the 2022 and 2023 numbers. Total overdose responses, fatal overdoses indicate, or as I said earlier, the patient was deceased at the time that the EMS medic arrived on the scene and they were not transported. This next slide is very busy. I'm happy to provide this to you all in more detail, but what this shows is the chief complaint as recorded by the medic when they responded, the type of drug. And these categories are not necessarily mutually exclusive. Some of it, you could have stimulants counted where you've got illicit as well as prescribed stimulants in the same category. It really depends on what was put in the chief complaint. But as you can see, when you break this down, we do see a decrease in your traditional prescription painkillers, oxycodone overdoses, and an increase in those illicit drugs, which again matches a lot of the data that we're showing from our EPI surveillance as well. That first grouping is all painkillers combined as a chief complaint, which is why that's the highest grouping. But this, again, a very busy slide, but happy to try to answer some questions on that if there's any additional details. Next slide. Looking at naloxone administration by EMS, this is an interesting slide. When overdoses decrease, you should see a decrease in naloxone administration. But what we're seeing is even though we're seeing a slight decrease in overdoses, we're seeing an increase in the total amount of naloxone administered. And as you can imagine, it's due to the polysubstance abuse. We're seeing a lot more substances that are being consumed that is requiring a higher amount of naloxone to be administered. And the line is sort of the trend. And on average, we should be administering about 0.4 to 2 milligrams of Narcan or naloxone, but our average is up to about 2.7 milligrams. And again, this is being driven by the illicit drugs, the stronger drugs that are in the system, as well as those polysubstances where there's multiple drugs in the system. And, the thing that is obviously concerning, I think, to us and others is those drugs that naloxone doesn't work on, like xylazine or some of the veterinarian medicines that are not opioids, but they're sedatives, they're tranquilizers. Naloxone doesn't work on that. And so it's certainly recommended to still give naloxone to help with the potential drugs that are in the system that it will work on, but it doesn't work on those types of drugs. And so that could be another issue that we face, or is an issue that we face. This is more of a geographical map that shows our EMS overdose response. These are EMS runs. And what I want you to take away from this is the map on the left is 2019 data, and the map on the right is 2023. And the map on the right's darker than the map on the left. That means there's more EMS runs that are happening related to overdoses across our state. And you can see the darker the colors, there's groupings of little areas of the state where EMS agencies, unfortunately, have been pretty busy with their responses to this epidemic. Next slide. And to kind of sum some things up, some of the emerging threats is, as I mentioned earlier, xylazine. There's metatomidine as one that came up in another state. That also is an animal tranquilizer that I believe it was Illinois or Chicago where they had an outbreak there. of that particular drug. We haven't seen that yet in the toxicology in Georgia. It's something we're monitoring for. But the xylazine has increased, the OD rate has increased by 10% in 2023. It's about a 1,600% increase from 2020 to 2023. And so we definitely are seeing more of these polysubstances. What has been explained is that there's a belief that it makes the high last longer to add more drugs to some of these other things, other types of substances that are being taken. But also the adolescent aged individuals that are using drugs. These numbers are small, but they do represent some large increases percentage-wise. If you look at any drug from 2020 to 2023, these are overdose deaths in adolescents from 10 to 19. It's increased about 93%. Again, the numbers are small. Keep that into comparison, but any number is a bad number. And related to fentanyl specifically, in 2020, we documented 14 deaths, and in 2023, 38 deaths related to that. So a 171% increase. And so these are things that we are monitoring. We're trying to tailor our prevention messaging and working with our sister agencies to reach this particular population and reach parents as well to educate. One other statistic I did want to mention, when you look, and this isn't in your slides, but I did look real quickly before I came here at the overall OD rates, overdose rates compared to other states, compared to sort of a national rate. And while we certainly have a lot of improvement to do in our state when it comes to overdose deaths, and there's a problem out there that we need to respond to, across the board, for any opioid type, the national rate is around 28.7 per 100,000. Georgia is 17.4 per 100,000. And when you look at all of the different drug classes, illicit manufactured fentanyls, heroin, prescription drugs, stimulants, cocaine, and meth, our rates are lower than the national rates based on the most recent data. Still, the rates are high, with the exception of non-opioid sedatives. We are slightly above the national rate in non-opioid sedatives that were found in overdose deaths. And this is things like the specific examples that was used in the data was gabapentin, kratom, ketamine, the totidine that I mentioned earlier, and xylazine. And so just something that I think as a state, we've got to continue to keep an eye on the pulse of this, and whatever the Department of Public Health can do to help educate in this area. We feel very confident in the data that we collect, and we think that the data can certainly be used to drive some very evidence-based decisions, and we're happy to be part of that solution. And with that, I'll be happy to take any questions.
Thank you. Good information, just what we needed. And, we'll still be working on this into November. So if some more updated data comes, please feel empowered to send it right on to Morgan, and we'll wrap that into what we're doing. Okay, so we're going to start right here, I think, with Mr. K.
Thank you for the presentation. I guess from a general standpoint in reading these graphs and statistics, if, say, for example, someone presented in an emergency room with fatal levels, however that metric is measured, of heroin and fentanyl, for example, how would that be measured in terms of cause of death? Let's say it's a fatal overdose. That's
so if we have the toxicology done and actually have the data, we could split it out and actually report it separately. It can also be recorded combined as all opioid types. The problem is we don't get toxicology from every single death. We have certain hospitals in the state, kind of a sentinel network of where we get toxicology data, and our public health laboratory does toxicology data. And so that's one area that, the more data that we receive, the better the picture is and the better graphics we can present on that.
So if we're not getting toxicology on all of them, which makes sense, if if we're dealing with a situation where there is no toxicology reporting done, do we not factor that into the statistics, or is there like and I don't always know how these emergency departments handle it. Do they make an educated guess, like this is what was found on the person, so we're going to assume this is what it was?
In some cases, a lot of our data comes from the medical death records report. And so we're basing it on what the cause of death is listed as. And so that if we don't have that toxicology, that's where we would use that data to make that type of decision in our data reports.
To a similar point, as it relates to opioid involvement or opioid involved emergency department visits.
Mhm.
If someone presents with multiple, there are multiple factors that led to the visit. Let's say someone was maybe crashed their car while they were under the influence of a substance. How does that get measured?
Well, again, I wouldn't make that decision. So it would be dependent on what the is called by the physician that calls that. And there's others that could speak to that more eloquently than I can. But I would have to get more information on that back.
I guess, is there any standard procedure that physicians are at least in theory supposed to follow in terms of reporting?
As reporting,
like the thinking how best to phrase it. In the situation I described where someone was maybe driving under the influence, how they're supposed to denote what the cause of the emergency visit was. There any uniformity across the state, or at least is there supposed to be?
Well, there would supposed to be. I would have to get that information back to you. I'll need to go back and look at our how that data is collected to provide a better answer for you on that. So I'm happy to provide that back to the chair of the committee. We're taking notes on questions that are being asked that we can't answer today.
It looks like. So next is Ms. Payton, please.
Thank you for your presentation. I do have two questions.
Sure.
So the first is, how are you defining a non-intentional overdose? Is that anything that's not a self-identified suicide attempt?
Which slide are you referring to?
Towards the beginning, I'm sorry, I don't necessarily know the number. But when we were referring at the beginning to non-intentional overdoses, measuring those, I'm just curious as to how you defined a non-intentional overdose.
So typically a non-intentional overdose is defined as someone or as an overdose that their intention in some cases, like you had mentioned earlier, we're not considering suicide as non-intentional.
Correct.
And so, I mean, that's generally an intentional way that someone wants to die. So they may be using drugs recreationally, they may be using drugs as prescriptions and they take too many. That would be described as a non-intentional type of overdose.
And is that just self-reported?
Well, it's reported. So if generally we get our data from EMS runs, whether they show up at the emergency department and that way, so they aren't typically self-reported.
Okay, understood. And then my second question is, it seems that stimulant use is on an uprise in Georgia. Has DPH been able to identify any correlation or causation between the stimulant increase and the crackdown on opiates?
It's a good question. We were actually discussing that yesterday, and we have not necessarily demonstrated a correlation, and it's something that we're looking into a little closer. Because if you noticed in the data that I presented, while we're seeing certain indicators decline, the stimulant indicators, prescriptions are increasing. And so one thing that we have seen is that for illicit stimulants like methamphetamine, cocaine, there is definitely seems to be a correlation to these polysubstance uses with the illicit fentanyls.
Thank you.
Thanks for the presentation. Here's some low-hanging fruit that I think we can maybe talk about with respect to naloxone availability, especially with respect to first responders or people responding in the field to overdose. We had seen a series of sort of news reports starting a couple years ago regarding availability and funding for naloxone units for first responders, in particular law enforcement and obviously EMS, where they were granted sort of by county, but that they would run out before the month was up, like it was like a monthly allotment. So a couple questions. Do you know approximately how many units are allotted per county, and is it per capita or is it pegged to the density of the overdose map that you see, like more towards counties that have higher overdose?
So I can't speak for the other agencies. So I'll just speak to how we allocate naloxone through DPH. Couple of concerns that has come up is that we're limited on what funds we can use to purchase naloxone. We are not allowed to use the federal opioid prevention dollars to purchase naloxone. That is one of the things in the rules of accepting that grant is we can't purchase naloxone with that funding. But we have received settlement dollars through the McKinsey settlement, and the original intent of those dollars was to provide naloxone to the first responder, primarily the EMS community. And we have a process where they can request naloxone based on their need. And so we do get requests from EMS agencies across the state. And we haven't run out of naloxone. We're still actually providing those based upon what's requested from those EMS agencies. We recently got approval to expand the reach of that naloxone to community organizations. Previously, it was just designated for our EMS. That's very new and very recent, and we're working with our public health departments to identify community organizations that don't have another source or funding stream for naloxone, but it is limited. Our funding is limited in regards to the amount of funding we have to purchase naloxone, and we're limited on the dollars we can use. And so, no, I understand the question and the concern. We're hoping that by expanding our reach with these community-based organizations, that we're going to get more out there in the community that's available that can be used across the state.
Can I ask a follow-up? So you said that the opioid settlement money cannot be used for
No.
naloxone.
The OD2A federal
OD,
grant
okay,
that
got it,
Department
okay.
of Public Health gets from CDC
Okay, good.
cannot be used to purchase naloxone.
So the follow-up question was actually about the opioid settlement money. So I know that some subset of that was already sort of divvied out for specifically naloxone kits for first responders. So what I thought I saw was about 2 million to you guys to distribute about 300,000-ish kits to EMS specifically, about 1 million to DBHDD for naloxone training, and then about 700,000 for law enforcement for naloxone kits. So we have a law enforcement officer here, right? So he can help us inform this. But is there need for maybe the law enforcement funding for Narcan to be higher for more kits? Because oftentimes they may be the first ones on the scene, especially if people don't think to call EMS, and EMS is very overstretched, as we know. They may not be there first, right? So it seems like the 700,000 for the entire state of Georgia for first responders, for law enforcement is maybe low. Is there need for more?
I personally, I advocate there's always a need for more naloxone, given the data that I just presented. I can only speak to what the Department of Public Health receives. And we do get a lot of requests for naloxone, and we're trying to get that out as fast as we can across the state. Your law enforcement certainly is generally the first on the scene, and if those are potentially missed opportunities that could potentially be that we could capitalize on. And so if there is more funding available for that, I think that would certainly improve our response.
Be a good budget, thought for next year.
Thank you, Chairman Newton.
Hey, thank you for your work and all you're doing. I did notice a couple of your slides pointed out that any opioids, and then it looked like the vast majority were illegally made fentanyls for the categories of those four. And then of course down here with this just fentanyl, and down below you got carfentanil and acetylfentanyl, I guess just newer versions. Or if public health had an infectious disease, you'd have a tracing thing to kind of go back and figure out what country TB came from or what area. But obviously tracing these back requires law enforcement capability.
Right.
how well does, and I know this is probably far off a little bit of our study committee, but certainly solving opioid related deaths is a big part of what we're trying to do. Is there a formal way you all work on these? I'm assuming most of these fentanyl ones, just from ER work, if there's not a suicide attempt note or something like that, usually it's assumed to be an accidental, either poisoning by improper amounts of fentanyl measurement, in a fake pill. How closely and how well do we work to get law enforcement involved, whether local or the Attorney General? I know there's the gang task force, but I don't know if the AG can go into getting down to all these deaths that have almost like an infectious disease tracking. Let's just track back until we find where did it come from? Is it coming across the border? Is it being flown in? Is it actually made in Atlanta or Augusta or somewhere?
So actually, most of that collaboration happens at the local level. And so our public health opioid staff, we provide data to them weekly. And they get very detailed data on whether there's been an increase in overdoses or increase in this category from week to week. Based on that data, there's limited, that we have to obviously ensure we protect, there is HIPAA protection. So we are limited in what we can share down to the detail, but we can share that there's a cluster of something happening in this part of the county. And a lot of I can speak from Chatham, for example, where we work closely with their CNT officers, and they will request data from us to be able to better respond. They have a prevention and education unit in the law enforcement side as well. And so it's, for them, it's about educating as well as the crime part of it. And so there is a lot of collaboration that's happening at the local level. That's why we fund a position in all of our health districts to be able to make those partnerships and to share what data they can. I think one of the issues that we run into is sometimes the data is not as current as it could be because there's always a lag in data, and getting that data to law enforcement in real time can be challenging at times. But when we are notified of a situation somewhere, and we do notify law enforcement at the local level to let them know what's going on so they can start also working to educate folks in that area and to respond to the crime. But to be able to track it back, I think that's certainly an area that we could work to try to improve upon. Because there isn't a really good, like you said, with infectious diseases, we have case investigations. We can track back usually to the case source. So that's the goal, at least. It's much more difficult to do that with some of these drugs.
I noticed just in the geographic distribution, when you do it by per 100,000, that blob of red around Atlanta goes down dramatically, and you see it across a lot of other counties in rural Georgia,
right.
Which may not even of Chatham County would not have the resources. It seems like state level coordination in this particular case, as opposed to a county of 10 or 15,000, trying their local law enforcement to do that, especially if it's been trafficked from other areas of Georgia or something. I didn't know whether you need some variants from, maybe the tools law enforcement has that supersede HIPAA. If it could be done at a state level, it's especially for the rural counties,
right?
Because otherwise it seems to outstrip their ability to really have the tools and the manpower.
Well, I do.
But I'd love it to be tracked.
I do believe that, and I agree with you. The better data that we can provide law enforcement, I think the better that they can respond. And so, we try our best to provide the most recent reports as possible. And that's something that there's always a lag, and that's something that we continue to try to improve upon. We do coordinate, closely with GEMA, with other agencies that work closely with law enforcement. And there definitely, I think, could be an opportunity there to look at better ways to coordinate and get this data out across the state to the folks that are needing it the most and the quickest.
All right. Well, thank you. I appreciate that. I know if we had infectious disease causing this many deaths in young people in particular, we'd certainly be working at the state level, and maybe we need to do something to give you you both, AG, whoever, GBI, whoever. Thank you.
Thank you.
Thank you. Mr. Pursley.
Thank you for being here, sir. So I'm looking at your slide with the overdose emergency department visits. I think it's like your probably fourth or fifth slide in. Understanding that you get the majority of your data from hospital visits, EMS runs, and the coroner's office, I'll say that, or death certificate. In these areas that you don't have much data, the fact of a lack of rural hospitals, or because the fact of lack of rural hospitals and other maybe not so up-to-date methods of sharing information. I'm sure some of these rural counties don't have the most accurate technology. I'm speaking from Southwest Georgia. How is the Department of Public Health making sure that they still engage out into the community in regards to educating the public and even using other sources to gather this data?
Sure. One of the things that we are trying to do, and we have a health department in every county. And this, opioid education is one of the missions of each public health district. So your district, Southwest District, as we call it. Albany is the lead county for that, or Doherty is the lead county for the Southwest Public Health District. And so, as I mentioned earlier, we do fund a position in every district, with the goal that that's what they're supposed to be doing, going out into the community, providing education, collaborating with the coroners, collaborating with community groups. One thing, though, that I think is probably universal in every county is the data that we receive through EMS runs is pretty universal. All EMS agencies are required to report data to the department. The department regulates the EMS community. And so we do get really good EMS data. And so that's one way that we're able to at least get a snapshot or a picture of what's going on. But I do think that it starts with the public health agencies and the districts providing and collaborating and working with the community in that area. We're always open for recommendations, and if there's ways that we can improve that, or if you need contacts or the law enforcement community needs contacts with who those individuals are around the state, we're happy to share that.
Okay. And just kind of a follow-up to that. Let's just say, looking forward into the future, I know some of the things you talked about, and on your slide, I think toward the end, your last slide about overdose deaths between the ages of 10 and 19. What efforts are being done with our school districts to do some intervention and prevention training?
Well, one thing that the legislator did at the last session was pass a bill that allows naloxone or requires naloxone to be stored at schools and to make it prominently available. We were tasked with putting together educational training around the use of naloxone. And that's just obviously one component. That's really responding to the issue, not necessarily the education side. But I do think that was a giant step to having that now, or seeing that be in the schools, so it's available. We work, and this is all over the state. We have a lot of relationships with local school systems. Most of the relationships begin, ironically, on the vaccination side. You ensure children are vaccinated to go to school. But it's those relationships with the school nurses that we're able to build. Our health education team around the state can go in and offer educational opportunities to the schools. Obviously, a lot of these opportunities require school board approval, or in some cases, parental consent. But we are open to offering education in the schools through our programs. And we already offer some education, and we can add this to that, provided that the schools approve us to do that. And I do think that's a good way for our health educators to to provide some initial education. But working with the school nurses, the school nurses are a great asset to public health. We work very closely with them across the state. They help us, we help them. And I think we all have the same goal of ensuring these kids stay healthy and stay in school. And so that's usually where our inroads are into the school, is working with those school nurses. And I think that's a great opportunity there.
Okay, thank you, sir.
Yes, sir.
And now Mr. Breedlove has a question also for us.
Madam Chairman, thank you. Can you hear me?
Yes.
Thank you. Wonderful conversation and presentation. I want to go back to the first slide on the EMS runs and just ask a generic question about EMS runs. And certainly, I'm just curious. I've been out in rural Georgia recently to 3 places that have tracking maps up where they've gone out based on some of the reports they get from DPH to go on the front lines. And some of the feedback I hear is, well, these numbers are underreported. And they're saying they're underreported because volunteer firefighters are on so many calls and they're volunteers and they don't have time to do all the paperwork. So they just save the life and go back to their regular life, or either a full-time EMS person just gets another call and they're busy. So I was wondering if have y'all thought about that perspective, that some of the numbers in real time in local communities, they kind of think they're still underreported, and how do y'all address that in terms of the perception versus the numbers you do get?
Sure. No, I think the point's well taken. We had originally rolled out a software called ODMAP, Overdose Map, and that's probably what you're referring to. ODMAP is a simple system where you can use your phone to enter very basic information that pops up on a map that there was an OD. The goal is that if you see a cluster, you can rapidly respond. We have been working to encourage volunteers, law enforcement community, others to use this software, because it doesn't give us a lot of detail of what particular drug it is, for example. But it does give us information that can be used, especially if law enforcement in that local community has that map up. They can start seeing those dots start popping up, and they know there's something that they can respond to very quickly. And so that is something that we have been encouraging. And as part of our public health education, we make that software available, and the training around that software available. Georgia is a big state, as you mentioned, and we do have a lot of rural areas. And there's certainly opportunities to reach more people and make them aware of that particular software. As far as official EMS runs, if an ambulance responds, there will be data collected on that. It's going to be dependent upon the chief complaint entered by the medic. But there is opportunities for trying to improve the underreported part of that. It's a very good point made.
Well, thank you for your answer. Yes, sir.
Thank you.
Thank you. Thank you for paying attention this whole time too. That's not easy to do from a distance. So appreciate you, Jeff. So next is Dr. Wang, please.
Thank you, Dr. Russin, for that enlightening presentation. I just wanted to focus on the PDMP.
Yes, sir.
As a physician, it really changed my prescribing habits. That launched approximately 2017. It may have taken me a year or so to get used to it. The data you presented from 2020 through 2023, which is 4 years, showed about a 10% drop for opioids, about a 7% drop for benzodiazepines, an increase I know we talked about with stimulants. I don't know if you have more data from the inception of the program. I'm a little, my habits have changed more drastically than what you've shown here, which, comment is just, it seems like we still need a lot of provider education, because I believe the drops that we see here, in my opinion, are minimal. I think earlier, Mr. Fox had showed us, over the the changes was about 40%, if I'm not mistaken. And maybe we have seen some of that here, but can you speak to a little bit on that?
Sure, sure. As you mentioned, when this system went into place, it was a big change in the state. Requiring, became a mandate that physicians had to look in the system. Some of the feedback that we receive and would like to receive is what reports, because we do provide reports back to physicians. We don't really call it a report card, but it does. We can provide like your individual prescribing practices as compared to your discipline. And the feedback that, we've gotten mixed feedback. Some physicians love it, some don't. It's kind of a mixed bag of what they like. Part of those reports is to provide sort of passive education. So the physician kind of sees, okay, my prescribing practices are here. This is where my discipline is. One of the goals of our program is, and everybody blames the pandemic, for everything, it seems. During the pandemic, we lost staff that was working in the PDMP. And I think our focus became so much on the infectious disease response at the time as it should have been, that we're getting back to sort of these very core basic programs like the PDMP. And so one of our goals is to work with the various medical associations, whether it's, whichever association it is, to provide education on the PDMP. And we would be open to, from physicians, like what do you want to hear? What is informative? What data can we pull out of the PDMP? Because we have access to a lot of data, and we can share it in an aggregated way that could hopefully help educate physicians to make good prescribing decisions. And that's really the goal. It's not, for us to tell a physician how to prescribe. It's to make them aware of hopefully that patient's prescribing history, so just good decisions can be made on whether or not that particular drug is needed. So we would be open to recommendations from physicians on how we can improve and provide better education across the board. But it's absolutely a goal of our program to educate on the system, not just how to use the system. That's the nuts and bolts of it, but the purpose of the system and the goals and what those look like.
Got it. Thank you. And just kind of a spin-off of that on the stimulants, that number going up with the prescribed, could that be due to the diagnosis of ADHD in all ages and the prescriptions of those medications?
I wouldn't consider myself an expert to speak on that. I think that's an area of opportunity for us to evaluate the data and try to see if there's any correlations related to that. And we're happy to look at that and try to share that with the committee.
Thank you.
Okay, any other questions? Not seeing any. I had one. When you spoke about the naloxone
Mhm.
and how you're having to administer maybe several doses
Right.
because of stronger drugs. I had someone visit with me in my office last year who said there is available a stronger dose at one time product that I don't know if there's any looking at that, considering that. And it basically, like you said, it's because of the type of drug that someone may have. And there's such a difference from that first responder who would know to maybe continue
Right.
versus the fearful person who might be in a state of panic, actually, have never used it before,
Yeah.
but have it. And I'm just wondering if we're looking at that at all.
Actually,
That double dose, I think is what it
sure.
was.
We've actually met with the representatives of that company.
Mhm.
And I believe they've recently got their product added to the state contract.
Good.
Because before I don't believe they were on that. And so we
Yeah.
have been in conversations about that higher dose,
Good.
or higher amount of milligrams that's in that dose that's available. And so those are on state contract now for purchase.
Good. That's good. That's good to know. Well, you have certainly helped us prove the need for us continue to look at the prevention efforts that we can here today. Thank you so much
Yeah,
for
thank you.
being here.
Thank you.
Right. So next, while they switch, we have a team, I think, from DBHCD that's going to present. Do y'all all want to do together or separately? Caleb McMicken will be first, I believe, and then y'all can all be there at the table. That'd be great. And then you can introduce yourselves as we begin. Is there a key that works over there? Is there an? Just go back.
Good afternoon, Madam Chair, members of the committee. I'm Caleb McMicken. I get the pleasure of serving as Executive Director of External Affairs at DBHDD, working with our communications and legislative teams. Having served this House for nearly a decade under 3 speakers, it's an honor literally to be home with you all today. So thank you for having me. Here to offer greetings on behalf of DBHDD's Commissioner Kevin Tanner. He apologizes he's not able to be here in person today. He's actually in Savannah presenting to the School of Addiction Studies. So we're attacking this problem in 2 cities and 2 fronts today. As you may know, Commissioner Tanner, in addition to his duties as DBHDD Commissioner, also serves as trustee of the Georgia Opioid Crisis Abatement Trust. The trust was established to steward the funds received through the national opioid settlements toward prevention, treatment, recovery, research, and education purposes, with the ultimate goal of ending the opioid epidemic. Today, you'll hear a presentation from Taylor Payton, Opioid Abatement Liaison and Commissioner Tanner's designee on this committee, and Melissa Malcolm, DBHDD Counsel specializing in opioid litigation and policy. These professionals will detail the trust structure and its work thus far. They'll also look into the future toward our first round of grant awards and beyond. As always, the Trust and DBHDD stand ready to assist the General Assembly in your work in any way we can. I would be remiss if I did not offer the department's thanks for the General Assembly and Governor Kemp's investments in our mission over the last several years and your continuing focus on improving mental health services throughout Georgia. If after today's presentation there's additional questions or further information we can provide, please feel free to call on me or our legislative team, Patrick and Kennedy, who are at the back of the room today, and we'll be happy to assist. Thank you again for having us, and with that, let me turn it over to my colleagues.
I'll just say it's good to have you back.
So prior going into the trust, I want to talk a little bit about DBHDD. We are the opioid authority for the state, and our main purpose is to provide prevention, treatment, and recovery resources for those in need. Our vision for fighting Georgia's opioid crisis is to reduce opioid deaths as well as dependency and improve population health overall. Our primary goals are to save lives, rejuvenate impacted communities, recover from and help them to recover from the opioid crisis. We need to increase access to both prevention, treatment, recovery, and harm reduction resources, as well as decrease the prevalence of opioid misuse and dependency and opioid deaths. Our primary recommended strategies, we would like to, our desired outcomes, are to decrease the number of new opioid users, increase access to treatment, increase access to recovery services, increase availability of harm reduction resources, as well as improve understanding of opioid misuse and dependency. Our primary goals are to implement school-based prevention programs, expand access to medicated assisted treatment, provide access to recovery housing, expand on naloxone access, as well as conduct research to understand the causes and consequences of opioid misuse. I'm going to turn over to Melissa.
Thank you for having us, Melissa Malcolm. The Georgia Opioid Crisis Abatement Trust, of course, is led by Trustee Tanner. This is the part of the presentation where I describe he wears two hats. Sometimes he's the director of the agency, but for the Georgia Opioid Crisis Abatement Trust, he is trustee. The first round of funding that's being distributed out of the trust itself is the manufacturers and distributors settlement. So the distributors, of course, are McKesson and AmerisourceBergen, which changed its name, now Cencora, and Cardinal Health. And then I think of it as one large settling manufacturer, all the forms of Johnson & Johnson and Janssen in that large corporation. This particular settlement is governed by not only the two settlement documents that are in excess of 650 pages apiece, but about a 20-page memorandum of understanding written and negotiated by Attorney General Chris Carr's office and signed onto by at least 244 local participating governments and sub-local governments. Keep in mind that while we start with a large number of hundreds of millions of dollars, that it's paid out over 9 years on the manufacturing side and 18 years over the distributor side. The MOU requires that 25% goes straight to those local governments. And then the other portion of that total that comes to Georgia is the 75% that goes into the trust. Within those trust dollars, 40% is required to be spent on a regional basis, leaving 60% for state funding. I try hard not to say statewide because we don't want to be too specific. The National Distributors and Manufacturers Opioid Settlement is governed by this MOU, which sets up a multi-level, got the org chart in a second, multi-level recommendation process that leaves the trustee as the ultimate decision maker for how the funds are spent, unless you're a qualified block grantee. So within that, we have the GPM, which we heard a lot about in state government until Governor Kemp renamed it when he appointed the 4 state appointees to the GPM. And that's how we got the GOSAC, the Georgia Opioid Crisis Abatement Commission. Then we also have, you can look at it as 11 regional advisory councils. So we have 6 regional advisory councils plus 5 qualifying block grantees. Most of those are also regional advisory councils. So here's the organizational chart with trustee at the top with the ultimate authority for that decision-making spending for that middle column and then the column to the right. He also has the requirement under the MOU and under the governing documents for the trust to do the annual reporting to the public. First report's already on the trust website. Then underneath here, if you look at the 2 orange rectangles, you have the regional advisory councils on the right and the qualifying block grantees on the left. Every qualifying block grantee, which is essentially the 5 largest local governments in the state of Georgia. So the 4 metro counties plus the city of Atlanta, Cobb, DeKalb, Fulton, Gwinnett, and the city, certify that they have the infrastructure in place to provide opioid abatement services. Once they do that, they will get their designated percentage straight from the trustee, then they make their own decisions. Regional advisory councils recommend up to the GOSAC. The interagency work group is an organization made up of subject matter experts from 3 different agencies within the state of Georgia: OHSC, the Department of Public Health, and DBHDD, who have been looking at the first round of grant applications to send the grades up to the GOSAC. Then all of these recommendations will be voted on by the GOSAC. That's 8 voting members, 1 non-voting member, non-voting chair, and then the trustee will make the decision. Oops, I went up and set it down. Here we go. This is how the GOSAC is currently comprised. Where's Chris Rustin, if he's still in the room, is one of the GOSAC members, and Cassandra Price, who also sends her regrets because she is also in Savannah, presenting with Trustee Tanner. And then Evan Fry is the corresponding liaison within the governor's office. He's the GOSAC liaison that works with Evan Myers as the chair. Additionally, and we've heard maybe some questions regarding this already today, we have the big 5 opioid settlement agreements that have already been entered into. Again, 25% is required to go per the second MOU to the participating local governments and sub-governments. And then 75% flows to the state. Within that 75%, 40% has to be spent on a regional basis, and it is required to go to the trust. The 60% goes to the Treasury for legislative designation. This is a summary of the total dollars for the big 5. Allergan, you can see these numbers. I don't want to reread what you might have already studied. I'll point out that Teva, which is a manufacturer of name brand, so Narcan, but naloxone, part of their settlement was to provide settlement product at the election of the states. And Teva is, the state of Georgia has already needed to make its first election. And Teva is currently shipping to Georgia, as on behalf of this settlement, 8,134 units of naloxone on a quarterly basis. The first one came in at the very end of May, beginning of June. That will continue to roll out for the first 2 years on a quarterly basis. These are those regions that I mentioned for all the settlements that have this regional allocation. They follow the same region boundaries as the DBHTD regions. That allows for administrative simplification, the referral processes that we already have in place as an agency, and data collection, which, as we've seen, is such a big, important part of this. And then the additional 5 regions are those QBGs I mentioned earlier. And now Taylor will go back to the clinical side and what we're required to spend the funds on.
So I know I've had a lot of questions about this, so I want to make this very clear. Our core strategies and approved uses. So we do have some core strategies for the funding. These are our priorities, such as expanding naloxone and medicated assisted treatment distribution, interventions for postpartum women, expanding neonatal absence syndrome, expansion of warm handoff and recovery programs, treatment for our incarcerated populations, prevention programs, and expanding syringe exchange programs. However, we do approve all uses within prevention, treatment, recovery, harm reduction, research, education, and evaluation. So all funds must be spent within these approved use categories. So after determining how we would allocate the funds, we did host a number of workshops throughout the state to educate individuals on how to receive funding. Within this slide, you'll see that we held a workshop in Atlanta, Brunswick, Columbus, Macon, in a virtual session. The numbers next to each location is the attendance we saw at that virtual session. So we were very optimistic about that. Within our first year, we will be dispersing $50 million to the state of Georgia. Again, this is broken up 60% to state, 40% to regions. You'll see next to each region, there is a percent of that funding that they will receive and a dollar amount they will receive. This number was determined based on a number of very specific measurements, such as overdose rates within that area and number of prescriptions, opioid prescriptions within that area as well. But there are numerous other measurements that went to determine these allocations. So after opening our portal and receiving our first round of funding, we did receive 208 regional proposals and 101 state proposals. You'll see that we were requested over $125 million from our regional proposals and $123 million from our state proposals. This chart here will show you the breakdown of how much money was requested and how many applications we received from each region. So if you think back to my previous slide, our RAC and IWG members will have some very hard decisions to make in terms of where to allocate funding. This slide shows you the number of applications and dollar amounts we receive from each funding category. So you'll see from our regional applications, we receive predominantly treatment and recovery applications, which does make sense. Those things are generally very individualized and local. For our state applications, we saw predominantly prevention and treatment applications, which prevention does generally take place on a statewide level. So this does mimic our grant, what we see in our grant requests. So this is, again, an overview of the process. Melissa mentioned this a little bit earlier, but just to reiterate, we began by first taking applications on our opioid portal. All of those applications were checked for completeness. They were then allocated to the correct RAC or IWG members to provide grades and final recommendations for funding. They were sent back, they will be sent back to me. And then go up to our GOSAC for final recommendations and then sent to the trust to make the final decisions for funding. So currently, our RAC and IWG members are grading those applications. We intend to get our recommendations back around September 2nd. This here is a QR code to our Opioid Trust website in our portal. It has a gap analysis, what we're doing now, what we intend to do for the future. So I'll give you all a moment to scan that if you'd like. All right, I'm going to go to the next slide. And then this last slide here is going to, if you're looking for a regional individual to reach out for, to understand resources in your area, what's going on in your region, please scan this QR code and this will give you a person of contact. So I'll give you all a moment to scan that as well. Wonderful. This is the contact information for Melissa and I, should you have any additional comments, questions, or concerned after this meeting. So thank you so much, and we will be here for questions.
You were going to begin with Mr. K.
Thank you for the presentation. Question about when funds are approved to be sent to a local government. So just a little bit of background to lead up to this question. I'm a commercial real estate attorney. I have most recently been, I guess more recently been involved in like local zoning matters for behavioral health clients of mine. And just earlier this very month, I was at a county commission meeting where on the same agenda, they were voting to approve accepting settlement dollars and also passing a new ordinance, putting in place a moratorium on approving behavioral health facilities because the state legislature in this past session passed a law repealing discriminatory waiting periods for drug treatment centers. It was House Bill 1073, and the county was worried, in their own words, that there would be a run on the county to open new treatment centers. So my question is, what strings, so to speak, are attached to providing these dollars to make sure, frankly, things like this don't happen, where they're taking money that is supposed to be aimed at the different metrics that you guys laid out. And then while they may be checking one or two of those boxes, they're doing things at the same time to undermine some of the other boxes. And in that case, treatment.
Well, thank you for the question. And I will say at the outset that given I can't speak directly to House Bill 1073 or its effects, I can say that those core strategies and improved uses is a summary. There's a particular exhibit that is on all of these settlements that's a little bit more detailed. Those are the specific legal strings on top of, we published the notice of funding opportunity on the website, and that's what we trained on. There will be additional contracting and reporting requirements as we move forward. I hope that answers your question.
Yeah, no, that's helpful. As a brief follow-up, are there, once funds are given to a local government, let's call it like a county government here, if they get approved, do they receive all of their funds in one tranche? And are there any I guess could you briefly, because I'm sure it's probably more detailed than what we have time for, but could you briefly describe like what the follow-up or reporting requirements of those local governments are to report back to receive the next tranches if it's funded in that manner?
One point of clarification. So the local governments, the 233, 244, depending on which settlement you're truly looking at, locals and sub-governments are already receiving their 25% directly from the national administrator, which goes by the name of Brown and Greer. And so there are local governments with checks already. So those same legal requirements go with that. And then to move forward to the reporting, it is what they received, what they approved, what the conditions were of that approval, and then what actually was dispersed. But per the 9 and 18 years that I mentioned in the presentation, that 25% will continue to flow out to those locals. And there are safeguards. That gets complicated.
Do local governments apply to the abatement trust for additional funds, or they're sort of capped at that 25%?
They are not capped. They may apply, and some already have.
Okay, thank you.
This time, I'm not seeing any other questions. Is there anything? Well, I want to thank y'all because you've given us some understanding about this. And certainly, as we all know, everyone is very curious about that money and where it might go and where it could be used. And as we dig deeper into ways to prevention, I know that DBHCD is where that really is best housed within our state to address the concern that we're talking about before someone is addicted. So I thank y'all so much for that and for the information we have here.
Thank you for having us.
Really good. Thank you. And thank you for the work you're doing. I know it's not easy. Also, so right now we have one person signed up, I think, to speak. Aubrey, is he? He stepped out. That's the only person that signed up. Is there anyone else who wishes to say anything today? We'll have opportunities for public comment at other meetings as well.
Madam Chair, members of the committee.
Yes.
I'm Aubrey Valance with the Georgia Chiropractic Association. It's been a busy morning for me. And I don't want to make a presentation, but what I would ask this committee to do is allow going forward, possibly in Rome, my association to make a presentation to the committee. I think they have something to offer. We've just received a $500,000 grant to look at the issue of alternative to opiates, and we'd like to make sure we use it in the right way. But we would like to share whatever knowledge we have with the committee. And if you would so graciously allow us to speak in Rome or Macon or wherever you find appropriate. Thank you. That's all I have to say.
Thank you so much for bringing that to us, and we'll discuss it, and we'll get Morgan to get back in touch with you about
Thank you so
what
much.
the needs might be. So, not seeing any other questions before we adjourn, I do want y'all to know our next meeting is scheduled to be in Macon, and we'll be sending out some more details about that. It will be in September, and look forward to seeing all y'all then. In the meantime, have a safe and happy Labor Day weekend. I guess summer's over, right? We'll be ready for fall when we meet again. Thank y'all for all being here, for the contributions you're making to this discussion. Appreciate it. We are adjourned.
Bye, everybody in Atlanta.
And we can